Vijay, you want to find out if Satish has joined it?
Can we call him?
Satish joined, but
yeah, his mic is off. He'll join. He'll join. Should we start?
Yeah, shall we start the session?
Yes, Vijay, up to you. Whenever you want to start. I'm sure Satish will join in the next 2-3 minutes.
So, at the outset, I would like to welcome all the delegates for today's discussion on skull-based paraganglioma. Today, we have an eminent group of panelists, which is going to be moderated by none other our Dr. Narayan Jaishankar from Mumbai, who doesn't need much introduction, but it is part of my duty that to him. He is senior consultant ENT and skull-based surgeon from Nanavati Super Specialty Hospital, Harvest, Mumbai, and Lilavati Hospital, Mumbai, who has about 21 years of experience in this neurotology and lateral skull base and transnasal endoscopic skull base and facial nerve are his area of interest. And he has published more than many articles in indexed high impact factor journals, and authored Atlas of 360-degree skull base surgery and also Atlas of neurotology and lateral skull base surgery, which speaks volume about his experience. And he has been invited faculty in over 200 workshops in and around India and abroad. So, this discussion without wasting further time, over to Shankar.
Yeah. Thank you very much, Vijay. Thank you very much, Vijay. I'll just share my screen. Okay, so good evening, everyone. I think today we are going to be discussing a very, very important topic, that is the management of skull-based paragangliomas. And today we have on our panel a very, very eminent panelist. Okay, I'll briefly introduce them. Dr. Satish Jain, although he doesn't require any introduction, I think I mean, with due respect to everyone, I think today he's the person in India whom everyone look up to for both his knowledge and his surgical skill. And he's from Jaipur, and everyone know he's got a factory running on Jaipur. And Satish is also the person who does 360-degree skull-based surgery, and one of the persons I tremendously respect and adore. Madhuri Mehta, of course, a very, very good friend from Hisar. She's the superintendent or medical director, and of course the head of the EAT department. I've known Madhuri from very, very early days when she was just about beginning her foray into skull base, and I can proudly say that today Madhuri is also doing fantastic work on both otology and rhinology also, and she's also authored a book on cholesteatomas. She's authored a book on osteocloplasty, and I think she's again on her way to authoring the third book, which is one on facial nerve. Of course, she's invited all over, and she's contributed chapters even to our the atlases which I have written. Sampath Chandra Prasad Rao, again one of the doyens from Bangalore. He also doesn't require much of introduction, but just a brief word about him. He practices neurotology and lateral skull base at Manipal hospitals at Bangalore and also at Apollo Spectra. And of course, he has worked with Professor Sana, but he's come back to India and he's very instrumental in starting his world skull base courses on lateral skull base and propagating the knowledge in India. And of course, he's got a tremendous amount of articles to his credit. Raghunandan, a very quiet boy, but an equally adept surgeon and a human being. If you see his CV, he's got an FRCS, MRCS, MCH, and whatnot. But he works at Madras ENT Research Foundation, and he's got a very, very keen interest in neurotology, lateral skull-based surgery, and implantology. Very quiet guy, but today you have him on the panel, and all these four giants are going to let us have a fantastic session. I hope you all people enjoy this session and hope we are able to pass on the correct information to all of you all. Have a good day. Before I go more ahead, I would like to thank Indian Academy of Otolaryngology Head and Neck Surgery Of course, the chairman of the Indian IAOHNS is Dr. Mohan Kameshwaran, and Vijay Krishnan is the secretary. Thank you very much, Vijay, for giving me this opportunity. And Dr. Gautam Khand, thank you again. He's the president of the IAOHNS. And of course, as you have all seen in the brochure, the academic program is supported by GSK. So quickly going into the topic, do you have my screen, all of y'all?
Yes, yes, we do.
Yes.
Okay. So Satish, I would like to know when you have joined in. If you have joined in, just say hello at a point in time. Okay. So coming down to this classification of the glomus tumors. Okay. Raghu,
Yes.
can you explain to us the class A tumors? Why is this classified as A1 and A2? And what is the significance and what is the surgical significance of classifying these tumors as A1 and A2? Let's go step by step.
Right. So, good evening, everyone. It's a pleasure to be among this eminent panel of skull-based surgeons. And it's a pleasure to convey the right information to the younger crowd. In fact, I think that this should all be addressed to the younger generation, young minds who are watching this, and probably they are the surgeons of the next generation. So hopefully they would take the right points home. So as rightly pointed out by Narayan, today the old fish classification has been revised and modified. And today, I think practically we are applying the approaches based upon the new classification. So I think apparently that way we could delineate between the extent of the tumors in the middle ear, the mastoid, in the hypotympanum, in the skull base per se, and along the skull base foramina slightly differently. So that is why I think this current classification, which has been put up by Narayan, is very important for the youngsters to understand. I think the classification from erstwhile 1 to 5 changed over again from A, B, C, D. Now they have been further classified as A1, A2, B1, B2, B3, etc. as you see on the screen. But apparently it just conveys the information with regards to identifying the correct approach towards the tumor for complete excision with minimal comorbidity and less amount of collateral damage. So I think class A, as shown here, would be isolated tumors which are seen on the promontory, which we would possibly be able to excise permeatilely. And A2 are those margins which are beyond, that is delineated on otoscopy, and they are slightly hidden. But class B tumors are those which are going beyond the confines of the...
Raghu, I'll ask Madhuri to maybe dwell on class B tumors. Is there anything else you want to say about class A tumors?
Not really. So I think basically there is a difference between the hypotympanic tumors and those tumors which are rising to the jugular bulb. So it is basically tympanicum going into the jugular bulb versus the jugular bulb tumors coming into the...
Okay, we'll come down to that.
Yeah.
Madhuri, do you want to discuss class B tumors?
Yes, yes. As Dr. Raghunandan has pointed out, the class A tumors remain restricted to the cochlear promontory. They keep abutting to that area only, mostly mesotympanum, whereas the class B tumor, they only arise in the hypotympanic area, though they do not at all involve the jugular foramen bone. So they are completely different from jugular foramen bone. They are further divided depending on their extent. Usually they remain restricted to hypotympanum. They are very easy. This classification basically makes us decide the right surgical approach for these tumors and differentiate them from the jugular foramen tumors. So B1 is restricted to hypotympanum. B2 is when it is extending to the involving the whole of the mastoid, but it does not affect the jugular foramen bone. And B3 is when it can erode the carotid canal in its vertical part or the carotid foramen only. So for limited, like this classification allows me to choose the surgical technique. For limited B1, I'll be doing only transmastoid mainly. And B2, again transmastoid, but B3, if it is extensive, I may need to do subtotal petrosectomy where we can have extend and go beyond the tumor in all directions. So class B is totally different from the tympanojugular tumors. These arise from the caniculi of the tympanum and the mastoid. They don't at all involve the jugular bulb, and the jugulocaryotico crest, which is gone in jugular tumors, it remains intact, and that is the differentiating point. Yes, Dr. Raghunandan was right. It is matter of this thing discussion that whether it is tympanomastoid going down or jugular tumors coming up. So there are
Okay, we'll discuss that. We'll discuss that. So
Yes.
just you all agree that class A1 and A2, the approach differs. And again, B1, B2, B3 is the surgical approach or the extent of surgery that differs. And that's how these tumors are classified as B1, B2, and B3. Right?
Absolutely. Yes.
Okay, so we are all on the same page on that.
Yes.
Coming down to the class C tumors, Sampath, would you want to dwell on that? Class C tumors?
Yeah.
I put a picture on the side. Now,
Yeah.
the idea of putting all these pictures on the side is for the junior audience to understand, rather than just talk theory, they'll be able to understand seeing the picture. So, Sampath, would you want to dwell on the class C tumors?
Yes. So one of the things that are often is often mistaken by some of the juniors is that they consider the tympanomastoid paraganglioma classification as a natural progression into the tympanojugular paraganglioma classification, just because the alphabets go from A, B to C and D. So it should be very clear, as Raghunandan said rightly, we should first make sure that the tumors are in the jugular foramen and coming out into the medial and medial cleft, rather than those in comparison to those tumors limited to medial cleft. So A, B, C, D doesn't necessarily mean a progression. These are two separate set of tumors. So class C tumors are tumors that begin from the jugular bulb but just about touch the petrous carotid canal entry point in the petrous bone. C2 is when they go along the vertical limb of the carotid. C3 is when they cross the genu. C4 is from there on right up to the foramen lacerum. So this is a very simple way of understanding the C classification. C stands for carotid. D obviously means an intradural lesion, D for dura. So again, here there could be pushing of the dura or frank infiltration of the dura and then an intradural extension. So this has to be very clearly ascertained during the pre-surgical evaluations. It's very important to differentiate between a dural push versus a dural infiltration and intradural extension, because if there's an intradural extension, you may have to resect the dura if it's a small dural resection, or this has to be left for a second stage if it's a rather large intradural extension. So again, I don't think it's very important. The DE1 and DI1 and 2 are not too important. It's more important for us to know whether the dura is infiltrated and the tumor goes intradural. The V classification obviously involves a vertebral artery. Vertebral artery involvement is very rare. Back at the group we saw about 7-8 cases, and that's the world's biggest series. I have seen just about one case and another case, which was managed by a partial resection of the vertebral artery. The other case was did not opt for surgeries, unfortunately, so I couldn't treat this case. So VE, again, the vertebral artery as it goes through the atlanto-occipital joint and the foramen magnum has an intracranial component and an extracranial component. So if the vertebral artery is involved in the extracranial component, it's a VE, and if it goes intradural, it's a VI. So it's a very useful classification. I think it's spot on, and it's a great classification to follow. And the problem is that the radiologists and the neurosurgeons have not yet fallen in line with this classification. There are other classifications which some of them follow, and I think it's important that we push this classification forward because it makes a lot of sense, and we make sure that the whole fraternity of surgeons and physicians who deal with these kind of tumors have the same classification. Standardization is very important.
Right. Has Satish joined in? Satish, can you unmute if you're on? Satish? Okay, I don't think Satish is on. Okay, Vijay, if you're off, if you're muted, can you just call up Satish and ask how much time he would take to join in?
Sure, we'll ask him.
Yeah,
sure,
thanks,
sure,
Vijay. Thanks. So I'll carry on with the discussion till then. So this picture on the left is for the junior colleagues. I know there are a lot of senior colleagues who will be watching, but this picture on the left is for the junior colleagues. What you can see here is the cochlea, and this is the course of the carotid. As you can see, this is the region of the jugular foramen, and that would classify as C1. The vertical course here, the tumors going along this area, the vertical course or the infratubal course of the carotid are C2 tumors. along the petrous part, that is the horizontal segment of the internal carotid artery, these are C3, and those tumors will go from the foramen lacerum or anterior face of foramen lacerum. They're classified as C4. So that picture is just kept there for the benefit of the junior colleagues, so that you're not scratching your heads as to what this classification is all about. Coming down to this picture, now all of us in our practice have had patients with an oral polyp. Okay, and I'm sure all of us at some point in time have had patients referred with complications of polypectomy, right? Someone has gone and done a polypectomy, or someone has taken a biopsy and some complications, and the patient has been referred to all of us. So maybe Madhuri, do you want to dwell on the fact, would you want to see this patient comes to your clinic? Would you straight go and do an oral polypectomy? Would you biopsy it? Or would you bother to investigate it first and then decide on the further management? What is the message that you would want to pass on to your junior colleagues?
Yes. So the patient coming to me with this picture, if it is pulsatile mass, then first thing coming in my mind would be this glomus tumor or paraganglioma or hemangioma type picture. If it is not pulsatile, we can think in different directions. Again, because that differential becomes so important to me, I will never ever take the biopsy. Biopsy is totally contraindicated in such cases. May it be hemangioma, we should not be taking the biopsy. What we should be doing is, first we listen to the history, long-term history. He may be complaining of other things also, like hearing loss, some lower cranial nerve palsy, some facial, some hint in the history. Then on clinical examination, I would like to examine every bit of his ENT, neck, and lower cranial nerves or facial nerve, and then get the most important investigation, which is CT scan, HRCT or CCT, and MRI. And those two radiological investigations give me the whole internal picture, as this paraganglioma have a very specific picture on CT or MRI. So CT basically will show me this placement in the jugular bulb area, and will give ISO or hypointense picture on plain CT. In contrast, they will be enhancing picture. Whereas in MRI, which is very, very specific, if this is a big tumor, T1 will be just simple intensity, but T2 will show salt and pepper appearance, which you can maybe tell in details. It is the flow voids in this hypervascular tumor creates flow void due to presence of vascularity, and hemorrhages lead to bright signals. So it makes a salt pepper appearance, which is very, very clear. And the only jugular tumors only give this kind of a picture. And then when we can find how further it is involving going around the carotid canal and intracranial or into the neck, all these things we can know from the investigations, radiological investigations. And coming to differential diagnosis, definitely.
Madhuri, let Raghu take up that second part, differential diagnosis.
Okay, so as Dr. Madhuri had clearly mentioned, I think the learning point for the younger colleagues of ours is to clearly identify, not only based upon the appearance as they would do an auto microscopy or look into the scans, but keenly evaluate in detail about what can be the differential diagnosis for this pathology. Primarily, the terminology of oral polyp itself is erstwhile, isn't it? So today we don't have a clear-cut pathology called oral polyp. So we should eventually find what is the pathology behind the diagnosis. So I would primarily say this is a vascular lesion if it is pulsatile, if it is blanching, and obviously if it is bleeding. So my first diagnosis would be obviously a glomus, so either a glomus tympanicum or a glomus jugular tympanicum, which is coming into the miliac cleft, coming through the tympanic membrane and causing this bulge. Obviously, there can be an underlying cholesteatoma. If you find something like this, it can be a big granulation mass, and there can be a hidden cholesteatoma beneath. We do find herniation of the dura and the meninges through the tegmen. Sometimes you can find a meningocele or meningoencephalocele. So be careful. Don't probe, don't puncture. You may possibly cause a CSF leak. Of course, we go have some kind of connective tissue disorders, tuberculous granulomas. We do find other middle tumors, benign tumors, lesions, which can also present this way. Finally, don't forget, in older people, think of malignancy as well. So you can find squamous carcinoma of the deep part of the explanatory canal presenting this way, or there can be a middle tumor or metastasis as well. So there's a quite a big variant of diagnosis here. I think we should be very careful in looking at the scans and the pathology on otoscopy to finally arrive at a conclusion. I would clearly follow what Dr. Madhuri had said, never probe this, never take a biopsy. And then whatever you do, you plan it in a right way and do a systematic approach for evaluating it further.
Sampath, you want to add anything?
Absolutely. The only thing I do in the ear is suction cleaning. Apart from that, there's nothing else. I won't touch any pathology. I don't go to meddle around anything in the ear, be it a granulation tissue, be it a polypoidal mass or frank glomus-like tissue. So I send the patients for CT at the least, or sometimes an MRI as well in case I suspect a tumor. And then I take the patient up for treatment directly. So no biopsy, absolutely, it's contraindicated according to.
So I think all the panelists are in agreement that there should be no patient taken up for an oral polypectomy or biopsy straight away. The first thing we do is investigate these patients either with a CT or CT plus MR. Keep the differential diagnosis in mind, see where this lesion is coming from, and then take the call what should be the further management. The reason I put up this slide is because many a time we have had patients, who have been biopsied. There has been so much of bleeding, and then someone has packed it and sent it across to us. Or sometimes the patient has had even a facial palsy and has been sent across to us because there has been differential diagnosis, one of facial schwannoma. Like Raghu has also said that there has been patients of CSF leak. So we've had all types of things, and I'm sure all of you all must have faced this in your practice. So the underlining message that we really want to pass on to you is always investigate, make sure you know what this is before you actually decide to biopsy it or then plan a surgery for the same. Okay. So going down to cases. Let's say we have this patient. This is the left ear of a patient. I've put on all my pictures of my patients. So this is a left ear of a patient. For practical purposes, you're doing an otoscopy and you see a red mass behind the eardrum. How would you investigate this patient? Satish is not joined in? Okay. So maybe Madhuri, you want to take this?
Okay, you have already put the CT scan.
Yeah, I put a CT scan because that's the first investigation we do, right? So you can see the CT scan findings. If Madhuri, you want to describe the CT scan findings?
I would like to describe it that if we start from above downwards, the internal auditory meatus seems okay till the internal ear seems perfectly okay. This is the facial nerve going internal auditory meatus, 11th segment, cochlea, lateral semicircular canal. This is first genu. And these are the antrum showing the heads of the ossicles. Now coming down, facial nerve seems okay. Mastoid air cells seem okay. Middle ear seems till now okay. Now coming further down, ossicles are absolutely fine. When we come to the level of middle mesotympanum, we can see a mass filling up the middle ear. Now this is a beautiful, well circumscribed mass sitting on the promontory area. You can see here, which seems the tympanic membrane seems intact. It is slightly going towards eustachian tube, it seems, but otherwise it is a well-rounded structure. And the important thing to see here is the jugular bulb is intact and the carotid canal is intact. So something sitting in the middle ear over the cochlear promontory, jugular and carotid seem intact.
Okay, so you can clearly see this lesion. I'm sorry, Madhuri didn't have the pointer. The pointer is with me. So I had to follow her talk and then do it. So, yeah, so Madhuri's pointer will not be seen. So this is the lesion that you can see, and you can see it going towards the eustachian tube. That's the horizontal segment of the carotid. I haven't taken very cuts much deeper down because there is no extension into the jugular bulb area. So you can see over here, this is the region of the ossicles.
You can see, Narayan, in the last picture, you can see the appearance of jugular bulb and it seems quite perfect in the last picture.
Yeah. So we're just about reaching there. Yeah, you're right. Okay. So what would be your management for this patient, Madhuri?
So this seems clearly as we go further. If I don't get a MRI, then CT seems sufficient. I will go.
So the question I want to ask you is, would you go about and operate this patient just based on the CT findings, or would you insist on an MRI?
We shall do the MRI. Exactly, I want to say. We may be having something on the, extension somewhere else in the intracranial or neck, and you should be looking into it that it is a vascularity, salt and pepper appearance. and further, maybe on the opposite side is the single side affected. So mostly when it is small tumors, we may go ahead and on the basis of CT scan also, we can go and operate this. And this is transcanal microscopic excision of the tumor. And most of the times people have started doing it through endoscopic approach also, but I do by post-oral approach, giving myotomy, lifting it up, and then, going around it, lifting the tympanomeatal flap gently, as you have already shown here. Tympanic membrane is lifted, and do two important instruments which really help at that stages. One, I have started using coagulation. And but I am very careful not to take it close to internal carotid or facial nerve. It is such a beautiful tool. It keeps shrinking the tumor. In between, I can shift to bipolar cautery when it is going into crevices. On the surface of the tumor, I keep using coagulation. As you told me, I have prepared a video, 4 minutes video. I can show in the end of that. So I'll keep shrinking it as you're showing it in the second video. Then we gently pull it down. The important thing is there is a keratico-tympanic artery, which is a branch of internal carotid artery, which should be delicately bipolar cauterized, because it can lead to a lot of bleeding if it is coming in the way. Then slowly, gently, we keep lifting it, and we can easily separate it. We don't even have to do anything with the ossicles of the mastoid. This much cleaning we can do with cautery of the vessels, and the surgery is done.
Okay. So since I have none of the panelists have seen these pictures, I've just put this for the junior people. I'm not supposed to be giving answers, but I just described these 4 pictures for the benefit of the junior colleagues. Madhuri said she takes a post-oral incision, and so do I. I take a post-oral incision, even if we could do this permeatally. The idea is I lift up the whole cuff of intact cuff of tympanic membrane. I lift it up completely. If necessary, in A2 tumors, you may even widen it, because you really don't want to be, working in a very small field. You use a bipolar, when you use a bipolar, the tumor shrinks and comes a little bit into your field, but don't poke into the tumor, just bipolarize it, so it shrinks again a little bit, comes in your field. Dissect it off from the vessel, from the malleus or from the incus and stapes area that you can see over here. Dissect it off, get it within your complete viewpoint. Lift up the tumor and then bipolarize the vessel on the promontory, as Madhuri has already told you. Sampath, there's also a vessel that comes from down here sometimes, where you see here, this is a bit of surgical. So Sampath wants to say anything about this?
So that's the inferior tympanic artery. In cases like this, what I would keep myself up to my guard is that area, the inferior tympanic artery, where we drill out. And then, so also Madhuri mentioned about the carotico-tympanic artery. What I've seen is sometimes, and we now have seen a lot of such instances where there are these aneurysmal cystic vascular formations around these vessels. So when you're drilling around the carotid, and the carotid tympanic is a direct branch of the carotid artery, so that's a little bit of a tricky situation where we'll have to drill, but yet because these aneurysmal cysts, they bleed a lot, but we know that it's not from the carotid. So you'll have to do a little bit of a balancing between surgical. You keep surgical sometimes, not get scared of the bleeder, and then go back to another area, take it out, and then go back and work near the carotico-tympanic. Of course, the inferior tympanic artery bleeds, and if you see the inferior tympanic artery, that is when you are sure that you've removed all of the hypotympanic extensions. And one more aspect of this surgery is the tumor course along the Eustachian tube. So if you see the scan earlier, you see that the tumor is going along the Eustachian tube very close to this foramen spinosum, which is where the middle meningeal arteries. So these give branches. So sometimes you end up following it fairly deep, which is when you'll have to do an anterior drilling of the Eustachian tube. So this again requires a little bit of training, drilling out the anterior the floor obviously is a carotid, so that requires a little bit of skull-based training. So I think these are the nuances of surgery. Obviously, I would go with your approach, post-oral, canal. Again, I would like the MRI to be done to make sure that the ear has only that it's not tumor and it's only some this thing fluid in the ear and not really tumor in the ear. So that's why I would do an MRI and then go ahead with this particular approach. And what you've done is brilliant, absolutely brilliant.
Yeah, so all of us agree uniformly. Just to summarize what all the panelists have said is do a wide excision, wide exposure, I would say, not excision, I'm sorry. What we do is take the tympanomeatal cuff off, because sometimes when you can even do a push all the tympanomeatal flap superiorly and then drill this area, but sometimes the burr tends to shred your tympanic membrane. So what I do is I take the whole cuff off. I use a drill machine and sort of use the drill and widen this whole area. And Madhuri said she uses coblation. I use bipolars. We just try to just gently bipolarize, and as Sampath also said, it goes into the eustachian tube. You can just gradually, it's just an extension, it's not really attached anywhere. So you can just gradually draw it back into your field. If necessary, drill a little bit more over there, expose a little bit more anteriorly. And then, of course, as you come down here, you have to bipolarize the vessel, which is either on the promontory, or in this case, apart from the promontory, there was an inferior tympanic branch, usually from the ascending pharyngeal, which comes in this area, and that sometimes you cannot able to bipolarize it, and then you would just put a little bit of Surgisil and keep it there. If osteocaloplasty needs to be done, you can do an osteocaloplasty at the same time, and then of course graft this here just as you would do in a tympanoplasty. So that summarizes the glomus tympanicum. Coming to the case number 2 here, Raghu, would you want to take up this case?
Yeah, sure. So I think we are seeing.
Raghu, sorry, I'm interrupting you. Has Satish joined it?
I don't think so.
He has messaged me that he is in an emergency case, so he will join once it is.
Yeah, okay, he'll come in soon. Okay, so let me know wherever he comes in, because we'll carry on with the rest of the panelists till then. Raghu, go on.
Right.
You want to describe this case?
We are seeing high resolution CT scan images in axial cuts. So basically, it shows a soft tissue mass in the middle cleft. Obviously, it is on the promontory. You can actually see the cochlear lumen just beneath that, and the carotid canal arising in front. And this soft tissue mass is also going down the jugular bulb. In fact, you can actually see the erosion of the jugular bulb, and there is a continuity with the hypotympanum there. And most likely, this is a glomus which is arising in the hypotympanum from the jugular fossa, coming into the middle cleft and going forward, possibly towards the eustachian tube. So, so this is definitely a vascular lesion. You can also see that the entire mastoid bone is all filled with soft tissue. Either it's fluid effusion because of the middle disease, or possibly the glomus itself, different venous lakes which are formed within the connections from the jugular fossa and the sigmoid sinus as well. So definitely consider.
I'm going to interrupt you. I'm very sorry about this. I'm just going to interrupt you. You're right. I know it looks a little bit eroded here, but I've not got the very good cuts here. But the jugular bulb here was intact. Okay, so it's basically a glomus hypotympanicum, which is really coming down. And the point that I really wanted you to make is, how do you differentiate a glomus hypotympanicum that's really coming down versus and goes down towards the jugular bulb versus a tumor arising from the jugular bulb, which is going up superiorly? So would you want to lay emphasis on that part? And right. This picture actually shows that there's a little bit thinning, but the bone is intact over here, okay? All over here.
That's right. So apparently we would like to see more high definition cuts and also compare that with the MRI scans and axial and coronal planes. So basically that would clearly show us the hypotympanic plate. And we would want to see where most of the soft tissue density is and most of the erosion is. If the caroticojugular spine area is eroded, we would more so think in terms of a glomus jugulare. If it's a hypotympanic vascular mass, obviously, as you had said, this plate is thinned out, but it's not fully eroded.
Yeah. So just to make it clear, this is a hypotympanic mass over here that you can see. You can see the carotid over here, and you can see the jugular bulb. Okay, the caroticojugular spine is pretty much intact. So the jugular fossa is unaffected by this whole tumor. This is a tumor which starts on the promontory and just goes down to the hypotympanum over here. And that's what I'm trying to depict in this picture. So Raghu, what would be your approach in this case?
So I would plan a mastoid exploration. So apparently I would want to have an MR angiogram. So I would like to see exactly what are the feeding vessels, if there is any direct connection with the jugular fossa, as you had said, to differentiate clearly between a hypotympanic and a jugular lesion per se. But it will be a mastoid exploration. I would follow a post-oral route. And especially I would like to remove the tympanic bone, expose the hypotympanum clearly, visualize the retrotympanum, and also saucerize the area below the tympanic plate, follow the part of the lesion around the jugular bulb. And as you would say, use the bipolar cautery, gently buzz the tumor as it would shrink, and gently dissect my plane towards the anterior hypotympanum and also in the perieustachian tubal area. And also clear up the disease from the sinus tympani. Make sure the facial nerve tract is clear on this area, and also work around the promontory and clear up rest of the disease. So it's pretty much like a glomus tympanicum surgery, which was earlier described by Dr. Madhuri. But I think this requires a little bit more of dissection. As you would say, this is not a straightforward mastectomy surgery, but it would require the nuances of doing skull base and working around the tympanic plate, working around the hypotympanum on the jugular bulb, and also retrotympanum, etc., are a little more challenging. Options are either you can go ahead, do a modified radical mastectomy, have a clear exposure to work on clearly in the hypotympanic area. And we can also try with a combined approach with an extended facial research approach. But it depends upon the intraoperative findings, I would say.
Okay. So in this case, what we did is we just widened the canal, went down right. You can see here to the hypotympanum. The canal, inferior canal wall was somewhere over here, but you've gone right down here to the hypotympanum. And you can see the bone is intact in the region of the jugular bulb area over here. Okay. And of course, we drilled a little bit towards the attic. You can just see that here the incus lenticular process was necrosed. So we have done an ossicleplasty and just sort of put a cartilage there to prevent the retraction pockets, because we drilled a little bit into the adductus to the antrum. And of course, then you put a graft in there and come out. So it becomes a glomus hypotympanicum, goes right down there. Of course, mastoid exploration is done when you suspect, as Raghu said, that the tumor is going into the mastoid, and you really sometimes need an MRI to differentiate whether it's really fluid or tumor going into the mastoid. Somebody want to add anything into this?
Yeah. If you see plus or minus erosion, Raghu said that there was an erosion. You said that the cuts don't really. When it's so close, I think an MRV is important. So an MRV would clearly tell us whether there is any amount of tumor within the bulb. Because I've had one case which looked exactly, I mean, these pictures were kind of a deja vu for me, because they looked so similar to one of the cases I operated. I thought it was a B2, B3, So removed of all the tumor, I could actually see the jugular bulb. We exposed the jugular bulb. It was a high jugular bulb, nicely shaved off the tumor. I could actually see the jugular, and I thought I did a great job. So after 2.5, 3 years, this patient takes a scan. This patient was from Australia, came down for surgery here. And he goes back, and then inside the jugular bulb, which looked absolutely the same as, obviously, you see, you must trust me that, the jugular plates were intact and carotid and all that. So I was pretty certain that we had not missed anything at that point of time. I was surprised that there was another tumor growing within the jugular bulb. And I say another tumor because I found no communication, or maybe there was a communication which I couldn't differentiate from the jugular bulb going along the sides or whatever. But it was, so once bitten, twice shy. So I'll do a MRV for this case and make sure that there is absolutely nothing in the bulb that's coming out. Or because if you see this, the pathology and anatomy of the glomus tissue, these tissues go along the inferior tympanic artery, which is very close to the jugular, just 1 millimeter adjacent to the jugular bulb. So they take a traction along the inferior tympanic artery, and some of them, and this kind of research I did only after I encountered that case. So, some of these tissues, they don't go by our classifications. The glomus tissue distribution along the jugular bulb and thereby into the middle ear doesn't go by our classification of B and C. So there is a track along the inferior tympanic artery of glomus tissues, and there is a foramen through which this comes out. And so this could carry some glomus tissues lower down, which may not be obvious in the beginning, but later on may turn into a frank glomus jugulare, the tympanojugular paraganglioma C1. So this is what happened to me. So I would like to put this on record.
Yeah, absolutely. So, I would like to add that in recent literature, they've been talking about petrosal venous lakes, because as Sampath rightly said, along the inferior tympanic vessels, there can be some multiple venous lakes which are running in the hypotympanum and retrotympanum, and they may connect to the jugular fossa when we are not really clearly able to delineate between the hypotympanic and the jugular lesions. Maybe there is a combination as well.
Yeah.
So one point, I want to put. Sampath has really put forward some interesting now topic, which really needs discussion. Sampath, I wanted to ask you, because literature says, and it tells us that glomus tympanicum arises from the paraganglionic cells around the Jacobson nerve, which is the branch of 9th glossopharyngeal.
Yes.
And this one arises from that of the vagus nerve, Arnold nerve, which is a branch of the vagus nerve.
Yes.
So these are two different sets of paraganglionic cells. Location is different. If tumor B finds a track and goes down towards the jugular, now the question comes, as you saw it in later stage, when patient comes again with that extension. So what should be our approach? Shall we treat it like a tumor B or tumor C? Because the two sites are different. It is just an extension. I think we should continue just going around and not going up to the level which we go for jugular, tympanic, jugular glomus tumors.
Yes.
If that was to me, I would like to, it's a brilliant question. And this is, I think, the future of where, the classifications would be going towards. So I think there would be a significant number of these tumors which would eventually end up with the C1 classification, C1 tympanojugular. So I got a scan done just to review annual review. It was not the patient had any symptoms. So his medial mastoid was clear, absolutely no problems. But he had this classical C1 within a jugular bulb. It was not even expanded. So we kind of picked it up.
Interesting. It is very interesting.
Yes. We kind of picked it up. It was not like it had come out of the jugular bulb and formed a classic C1 tympanojugular C2. So it was a C1 very much inside the jugular bulb, which we picked it up simply because we did some annual post-op scans. Follow-up scans. And in this case, I think it has to be dealt as a separate tumor. Now it is a C1. Earlier it was B2, B3. And the C1 tumor is now I'm following up the patient. I'm just waiting. He's a young guy. So I'm following this patient up and let's see what will happen. I mean, eventually I may opt for radiation.
So if I may summarize what the panelists have said for the younger generation people, okay, when you see these tumors, always follow these tumors down at the console. Okay, go to the CT scan console, follow it millimeter by millimeter or even lesser, very high definition cuts. See if your jugular bulb is intact. If the bone over your jugular bulb is intact, then you would consider this a B-type tumor, and then you would think of doing a different approach compared to a C-type tumor. If your jugular bulb is eroded even partially, as in this case, it could still be a hypotympanic tumor causing a jugular bulb erosion. It's not necessary that it's a jugular tumor, though Sampath's case was a jugular tumor. Okay, so C1 tumors would start from the jugular bulb, and the difference is that in a C-type tumor, you would go for an infratemporal fossa A approach, and in a B-type tumor, you would go for a much limited approach. And that's why this discussion is very, very important, what we are saying. In cases of doubt, you have to really study your scans well, and you have to back it up, as already told you by all the panelists, with MR and especially MR venograms, which will definitely tell you whether the tumor is really involving the jugular bulb from top, compressing on the jugular, or whether it's actually coming from the jugular bulb. You're most often than not, you'll be able to make the differentiation, except in a rare case, you probably miss a differentiation. I think that's the message that we all really want to pass on to you. So this case, as I showed you, turned out to be a hypotympanicum, and we got away doing this. You can see the plate is here. But if there is on the reverse a jugular tumor coming up here, as it would usually do, the approach would be very, very different. And that's the very basis of this discussion, is your complete tumor, your study of your scan will change the approach by which you deal with this tumor. Completely changes the surgery. You cannot substitute one surgery of a B-class tumor with a C-class tumor, right? So coming down to this another case, I know the scan is not that good, but let me just put it across to you all. This is a glomus mastoidalis, okay, coming from middle ear to the mastoid again. Raghu, would you want to take up this case and describe what we would do? I think you've already spoken about it, so we'll just describe it very briefly.
Yeah, so I think there's just a soft tissue mass filling up the entire medial cleft and the mastoid. Obviously, eroding the ossicles. I can see that it's also going into the retrotympanum, into the adductus, into the mastoid, around the lateral canal, and I think the internal artery canal is preserved, but rest of the mastoid is all destroyed. I think the OT capsule seems to be intact. There is no erosion of the posterior fossa table and no anterior extension towards the eustachian tube. The carotid canal and the eustachian tube seem okay. I can't comment any more rather than look at different cuts.
So how would you plan this? Would you plan this as a canal wall up, canal wall down? Are you particular about it? How would you approach this tumor?
I would pretty
Doing
much,
this, it's limited extension into the say mastoid.
I would rather pose this as a mastoid exploration, and on table I would plan according to as the pathology leads me to. So I think apparently doing an anti-tympanotomy, exploring the middle contents, and also do a thorough mastoidectomy, a clear exposure towards the adytus, clearing up the disease over there, and working from both sides. Maybe even I would probably try a combined approach. Because I do see that the posterior canal is quite intact. I don't think there's much erosion into the posterior canal, except for a bit of the annulus and around the peri-adytus area. So if I'm able to remove the disease with a combined approach, that would be a good limited approach.
Raghu, 1 second. Has Satish joined him?
Hi, Narayan. Sorry for being late. Sorry, I couldn't join because of some unavoidable circumstances.
No problem,
Really
Satish.
sorry for not being on time. Hi,
Not a problem,
Sampath,
Satish.
Madhuri, how are you?
Hello, how are you, Satish?
Good,
Nice
good,
talking to you. Welcome.
I'm
Good
really
evening,
sorry
sir.
for
How are
being
you?
late. I told you, Narayan, for some reasons I
Yes,
couldn't
I
join.
agree. Yes. So
So-
Satish, welcome to the panel. We were just discussing various aspects of tympanicum. We just went past hypotympanicum tumors and how do you differentiate these tumors which go down from the hypotympanicum and those which come up from the jugular bulb. We discussed that, and now we are into mastoidalis. Okay, and Raghu was just talking about how to deal with tumors that just extend a little bit into the mastoid. Yeah, go on, Raghu.
Yeah. Hello, Dr. Satish. Thanks for joining.
Thank you, sir. Thank you.
Yeah, so I was just talking about the scans that I see here. It seems like a vascular lesion filling up the middle cleft, extending down into the mastoid. The inner ear seems to be preserved. There is not much of an erosion into the pericarotid or the eustachian tubal area. The plan of approach would be pretty much a mastoid exploration. And I would decide on how much I need to dissect based upon the pathology where it leads me. I thought a good option would be to do a thorough cortical mastoidectomy, visualize the adytus antrum area, and also look clearly into the middle cleft through an anti-tympanotomy approach. Maybe posterior tympanotomy with a combined approach would be a good one. But if there is disease which I cannot dissect without removing the canal wall, then possibly a modified radical mastoidectomy is also a good option. So I think that is the right way to approach this.
Any panelist wants to add anything onto this?
I just want to add 2 things. One thing is with the intact tympanic membrane, soft tissue sitting there and slight extension into mastoid, it gives me to just rule out congenital cholesteatoma also. Maybe I would definitely go ahead and get a MRI done to rule out that. And a second thing is, if as usual, as in type B, class B tumors, they keep restricted to the inferior part. I mean, hypotympanum and inferior part of the mastoid cavity. As Dr. Raghu was telling, the posterior canal wall seems healthy and intact. So what I can do, I can thin it, take it out, resect it, remove the tumor, and then reconstruct the posterior canal wall. This is one step, a bit of differentiation. Otherwise, modified radical, canal wall down mastoidectomy can also be done.
Yeah,
Depends on
Narayan,
the.
Yes, Satish, go on.
Can I add one thing?
Absolutely, go on, Satish.
Yeah. See, once you have a clinical diagnosis of a tympanic paraganglioma, like otoscopic picture, clinical, symptoms, whatever, and you have this kind of scan.
Yes.
With the CT scan alone, you can't differentiate whether this is secretions or tumor, wherever it is.
Absolutely,
You
absolutely.
cannot say in the mastoid is a tumor or secretions.
Correct.
There could be tumor in the middle ear, but you can't differentiate where the tumor and where the secretions are. So for surgical planning, because surgical planning depends upon the extension of the tumor going to the attic, going to the retrotympanum, mastoid, wherever. So you need a proper MRI. MRI is the investigation of choice. A contrast MRI will tell you where the tumor is, where the secretions are.
Correct.
That will help you plan your surgical approach in a proper way, what I believe.
Absolutely, Satish. We discussed that first, that we would back up every case of glomus with an MRI, not just a CT scan alone. And Satish has put forward this. And Satish, since you brought about that point, why CT should be backed with an MR always, would you also want to throw light on this picture on the left and right? You have just joined the panel. Of course, this was a glomus on the left side of one of my patients, but I put an arrow here. Satish, do you want to describe this and talk about this and the right picture as well?
What arrow? This is jugular. On the right side is the jugular bulb.
Yes.
So what do you want me to do?
No, I'm talking of this. So you would raise your horns up. You know, these are the differential diagnosis of lesions which are mistaken for glomus doing only a CT scan. So
Yes.
CT scan alone, if you have to do a CT scan, you have to really study your scans. That's why I put the title in red, that, you know, you really have to understand. A high jugular bulb, you cannot be mistaking it for a
Yes.
glomus,
Yes.
right? And similarly, this picture over here, Satish, is an aberrant carotid artery. Okay.
Yes.
So this, if you see, there are 4 pictures of here. Of course, this is taken because I couldn't show you sequential pictures on my one of my patients. But you do have aberrant carotid arteries here, and just relying on the CT scan, you could mistake this as a glomus, seeing a single cut or few cuts,
Yes.
and then you go about surgery, which could be disastrous. Satish, you want to add something on this?
Yes. So the bottom line is MRI is important to differentiate soft tissues.
Yes.
CT alone cannot differentiate what exactly the soft tissue, depicted soft tissue is. It could be secretion, could be tumor, could be aberrant vessel, could be like high jugular bulb, aberrant carotid, secretion, cholesterol, whatever it may be. It gives opacity on CT scan. Doesn't differentiate at all. Yes, on contrast, you can say something is taking up contrast, you can assume as a tumor. So rather than taking into consideration CT scan sole as a diagnostic test may not be fair, you need MRI.
Yes. So again, the summary is, for all these tumors that we discussed, there are many patients who send across patients for surgery or even do surgery based on the CT scan alone. The underlining point is always do an MRI to back your findings, because today MRI is pretty much indispensable for anything. Okay. And I think Satish has also got a lecture on how MRI is game changing for various lesions, right? So anyway, we'll discuss that later. So underlining point is that we should do MRI for all the cases. Okay. Satish, you've joined in late. I'm going to give you a few more questions. Do you want to talk about this tumor? This is, of course, a glomus jugulare. You have got these cuts. I don't use the, I've not put it on a dicom as because I'll have to keep switching on and off. I've taken everything in a single cut, but would you want to describe this tumor a little bit? And what would you think of this tumor?
This tumor lying on the promontory on the right side, is it?
It's coming from the jugular bulb. You can see the jugular bulb erosion everywhere. It's a glomus jugulare.
Jugular bulb erosion coming into the hypotympanum, coming into the medullary cavity. And see on this, this is not comparing both sides. What I can see, this is sort of, distraction of the jugular foramen, a sort of irregular distraction of the jugular foramen.
Yes.
And something opacity from there in continuity projecting into the middle ear.
Correct.
So looking at the clinical findings, if we correlate, if clinically it goes in favor of some paraganglioma, it could be a jugular paraganglioma. Solely on the basis of CT scan, you can't make out everything crystal clear. You need some more information from imaging. You need a multiplanar, you need an MRI, and you need other clinical details as well. But what I see here is an irregular sort of distraction of the jugular foramen, and from there in continuity that opacity is continuing in the middle ear.
Correct.
This could be, if clinical diagnosis supports, could be a jugular paraganglioma.
Point well taken, Satish. Okay, come down to this picture again here. You can see some destruction over there.
Yes. This is pure destruction of the jugular bulb again.
Yeah.
On the right side, destruction of the jugular bulb. And if you compare with the opposite side, normal jugular bulb.
Yeah.
Yes.
See on the opposite side,
Yes.
normal jugular bulb. In the lower left picture, you can see the normal jugular bulb very clear. On the opposite side, enlarged sort of moth-eaten appearance of the jugular bulb. And this is extending superiorly towards the middle ear. That is what very clear from this CT scan.
Yes.
And again, it could be jugular paraganglioma if I am blinded with the clinical details and MRI and other details.
Correct. So you would use a MRI to back this up. Obviously, point well taken. Is a CT scan useful, Raghu?
Yes, I would say definitely there is an enhancement in the jugular fossa on the right side. The mastoid bone itself is pneumatized, but you can actually see that mass is chewing up the jugular plate and the hypotympanic petrous bone. So beyond that, I would probably say that the disease is going forward as well around the carotid and eustachian tubal area anteriorly. And I'm not able to delineate how further down it is going down, but probably I think it's going around the down up to the styloid process as well. And you can actually see that it's going down in the infratemporal fossa. You can see that this is almost abutting the medial pterygoid and the infratympanic space, temporal space, and the medial post-styloid compartment of the parapharyngeal space.
Okay, so more than dwelling on this, I know these pictures are not really up to the mark.
Yeah.
Would any one of the panelists ask for now? This patient came to me with this picture, okay, with the CT scan and this CCT. So would any one of your, let's say, Sampath, would you advise any further investigation, or would you just base your diagnosis on this and go about and do surgery? Would you do any other investigation?
No, this I would definitely ask for MR with the MR angiogram. Now, if you look at the tumor extensions, Narayan sir, if you can just go to the first slide, I mean 2 slides before, one more. Yes, if you see, there's very little tumor in the middle. There's absolutely nothing in the mastoid. Some tumor in the hypotympanum, and the rest of the tumor is all in the jugular bulb, abutting the carotid, and it is abutting the carotid in the vertical canal, so C2. And then if you see, it goes up to the petrous apex. If you look at the second row, third picture, fourth picture from the left, yes, exactly there, it's going into the petrous. So it's there. So, and then a lot of tumor is in the infratemporal fossa, so to speak, outside the bone, So I would say 1/3 of the tumor within the bone, about 2/3 outside. If you then go down to the next couple of pictures in the scans, CT, based on CT alone. So yeah, it's a little unusual kind of, but yes, tympanojugular paraganglioma never cease to amaze. This could very likely be a C2 TJP, but I will definitely keep a diagnosis of a vagal paraganglioma in mind as well.
Okay, I'm just going to go ahead on the MR. This is the MRI of the same patient.
Yes.
Okay. I'm planning to put all of it together, but maybe Sampath, you want to take this on?
Yes. Brilliant. So this, if you see the last 2 pictures on the lower row, last 2 pictures are, yes, the pictures on the right, the last 2 pictures on the right, you see a nice petrous extension behind the carotid. So now how do you classify this? So this becomes a C3. So it's practically going up the foramen lacerum. No tumor in the mastoid midlia. Isolated extension in the petrous. So it's, I mean, if you are talking about foramen lacerum, this is foramen lacerum here. So it could be a C4, but then it doesn't really fit into the C4 scheme of things. So it's a very interesting tumor for me. Jugular foramen tumor, going isolated extension into the petrous in the subcochlear area, expanding the jugular bulb medially, and then a lot of tumor inferiorly. If you see the top row from the left, yes, so that's where the tumor ends. That's practically, medial pterygoid, halfway through the medial pterygoid. So yes, could be a C2, but I would not, rule out a vagal paraganglioma as well, because vagal paragangliomas stay much more medial. They push the carotid anteriorly, go into the jugular bulb in the more medial compartments, and they climb up into the petrous.
Satish, you want to add anything onto this?
Yes. So Narayan, first of all, I'll come to your first question about what investigation I would order. See, we have, once we suspect some paraganglioma, nowadays we have changed our investigation protocol. Rather than getting a contrast CT scan done, we get a CT angiogram done with itself with a contrast CT scan with details information of the angiogram. That will give you proper information regarding the vascularity going to the tumor to diagnose a paraganglioma. Rather than a contrast CT, a CT angiogram along with a contrast MRI.
Okay.
That will give you complete information. See why this MRI, additional MRI is needed, why CT angiogram is needed. For a proper diagnosis, number one, MRI will tell you a proper salt and pepper appearance if it is a paraganglioma. That is classical on T2 weighted imaging, you can see even on contrast as well.
Correct.
Number two, it gives you a good relationship, or I would say the best information regarding relationship with the carotid artery, with the dura, or any other soft tissue critical structure. which CT scan cannot give. Number 3, regarding any extensions beyond the jugular foramen, like this tumor, you can see that the jugular foramen is eroded and going anteriorly to involve the carotid artery. Like Sampath has already described, this is extended to involve the carotid artery, and even at the, you can say C3 as the horizontal carotid artery is also looks like involved. So this tumor from below up going beyond the genu of the carotid, you can say, this looks like paraganglioma, though I don't see very clearly on these MRI pictures rather than what you see on the DICOM, but it looks like a paraganglioma.
It was in fact a paraganglioma, but some pictures, go on,
rather than a vagal paraganglioma. The reason being, vagal paragangliomas first expand to the path of least resistance in the parapharyngeal space. Once they extend more in the parapharyngeal space, they tend to extend up towards the jugular foramen and then intracranial. So this particular patient, I don't see too much of parapharyngeal extension. This looks like to me a jugular paraganglioma with inferior extension, you can say, rather than a primary vagal paraganglioma.
Yeah, it turned out to be a tympanojugular paraganglioma. I mean, jugulary, of course, with all these extensions. I deliberately put off just very few pictures over here because sometimes people tend to do surgeries based on very limited cuts. So the whole discussion is based on this MR findings. You have to have a T1, T2 post-contrast films. You have to have, like Satish says, I'll talk to you why Satish does a CT angiogram. We'll come on to that. Okay, let's go on to that, Satish. You talked about CT angiogram. Would you do a CT angiogram and why would you do a CT angiogram? And then, of course, the other panelists I'll talk to and ask whether you do an MR angiogram, which patients you would select. Would you do this routinely or otherwise? Go on, Satish. You want to talk about your protocol?
Yes.
Say you're suspecting a glomus jugulare, say on CT scan.
Yes.
What is your investigation protocol? Please repeat.
So my first investigation of choice, if I am to order, if I am supposed to order, is a CT angiogram, which gives you a contrast enhanced CT scan along with detailed information of the vessels supplying to the tumor. And our policy is to look at the angiogram ourselves, how the vessels are supplying the tumor, which vessels are supplying, and how they are entering into the tumor. So that we can have a complete information of the vessel supplying. Our policy in our practice is we are not strong proponent of embolization.
Yeah, Satish, I'll come to that. I know why you're doing CT, I'll come to that. But just talk to me about your investigation protocol.
So first is CT angiogram, then a contrast MRI, which gives you, along with the diffusion and T2 weighted, of course, which gives you a more specific diagnosis of a paraganglioma with salt and pepper appearance of the paragangliomas, and a good relationship with the critical structures like carotid, exact extensions towards the cranial cavity, if it is extending to involve the hypotympanum, jugular, well, anywhere it is extending, the MRI will give you exact picture of the tumor extent rather than a CT scan, which cannot differentiate between the tumor and the secretions or mucosa or whatever. MRI will give you exact description of wherever the tumor is extending to.
Absolutely agree with you. Satish, Madhuri, do you do an MR angiogram, venogram? If at all you do it, when do you do it?
And
yes,
just I forgot to add one thing.
Yes.
When we get the CT angiogram, at the same time we get the venogram details also. Because once you suspect a paraganglioma and plan your surgical approach, your detailed information of the venous system is also required. With the contrast enhanced CT venogram, you really get to know what is the venous circulation happening on the opposite side, whether the paraganglioma, if it is a jugular one, has still circulation in the jugular bulb or it's completely closed or completely blocked, you can say. And that's a very, very important finding in terms of decision making. So CT venogram is a much better investigation than MR venogram because MR venogram is without contrast. CT venogram gives you exact information of the flow of the blood if it is carrying the contrast, which tells you whether the jugular bulb is clogged with the tumor, whether there is flow or no flow.
So Satish?
Yes.
Satish, can I ask you?
Yes, madam.
And when you get a CT, angio and venogram, then you get MR also, MR angio and MR veno also?
No MR angio venogram.
So you
only
MRI on CT, angio and CT venogram. Because
MR,
they are using contrast.
Yes. MR angiogram is a good investigation which you can get done without giving contrast.
Yes.
But once you need to know the flow, blood flow passing through the veins or anywhere, you need to have a contrast study so that you can see the contrast flowing. And that is best depicted by a contrast and then CT angiogram.
You only
Madhuri, what is
when there is a contraindication for contrast.
Yes, then MR angiogram, of
And
course.
that is MR is the choice.
Yeah, but that cannot show you the flow in the jugular bulb.
Madhuri, what is your investigation protocol?
Basically, MR angiogram to see the blush and also see feeding vessels, and MR venogram to see the venous status of the same side and the opposite side.
Any change, Sampath? Anything in particular you do differently or same?
I would like to do MR angiogram for all cases, obviously, because we will embolize it. But then I think Satish has a different policy. But MR angiogram goes with MR angiogram. I need to know the carotid. I need to do a 4-vessel angiography. MR venogram. So this much is for me mandatory for all tumors. Now MRV, where I would like to do MRV is again, the vagal paragangliomas which go into the jugular bulb to see if there's any flow where the jugular bulb is compressed, and then the vagal tumors which expand the jugular bulb to see if there's any flow through the jugular bulb. But if it's a classic jugular tumor eroding the whole bulb area, then I would probably skip MRV and stick to an MR angiogram. If it's a very big one, destroying the jugular bulb in a very classic way, then I would probably compromise on the MRV, but definitely I would go for an MR angiogram.
Good. So to all the delegates watching, you're seeing a debate between MR angiogram versus contrast enhanced angiogram. And we'll talk about this further. We'll tell you why Satish is doing what he's doing. But Satish, just since we are on venograms, contrast enhanced, I put a sentence over hypoplastic jugular venous. You said if it is there, you have a decision to make. What is the decision you make with a hypoplastic jugular venous system on the opposite side and a glomus jugulare on the one side?
Yes.
What is the decision you would make? Yeah.
Yeah, Narayan. Coming to this, before I would like to add on what I said earlier.
Yes.
You asked for the diagnosis or investigations are CT angiogram and MRI.
Yes.
Now, once you plan surgery,
correct.
For surgical planning, then you need DSA once the tumor is involving the carotid. Any tumor involving the carotid, to stay on the safer side, you need an angiogram for many, many things. Not only for diagnosing multiple lesions, if any, to give you complete information regarding the feeders, to give you a complete information about the carotid involvement per se, the carotid wall involvement, compression, whatever, and more importantly, to give you information regarding the cross flow at the level of circle of Willis.
Yes.
All that you need in the angiogram, but that is when we do DSA only once you plan surgery, not for the diagnosis. Number one. Now coming to the venogram to see the hypoplastic, if there is hypoplastic, jugular circulation on the opposite side. See, if you have a hypoplastic circulation on the opposite side, and on the same side with the jugular bulb tumor, where still the flow is intact, I would like to observe. If the flow is clogged, flow is gone, there is no flow in the jugular bulb, then you already have an alternate system working. Then there is no risk in even surgical planning with a hypoplastic jugular bulb on the opposite side, because there are so many alternate pathways working in spite of a jugular bulb with no flow. There could be vertebral system working. There could be sufficient hypoplastic system opposite side which is giving flow, which is adequate and not giving any problem with the jugular bulb blocked on the opposite side. The problem is when the tumor with the flow in the jugular bulb and the hypoplastic system on the opposite side, then you have to, that is a wake-up call, then you have to wait and take a call accordingly.
Fantastic. Point well taken. Any other panelist wants to add anything, or should we go on to the next point?
Very beautiful point given by Satish, that when there is flow, that means collaterals have not developed, and we should be very careful when the other side is hypoplastic.
So
I would just like to add something to what Dr. Satish had said.
Yes,
apparently, the main differentiating point is also to look at the other dural venous sinuses. As Dr. Satish correctly mentioned, if this jugular bulb is already occluded, automatically your petrosal systems and your venous drainage on the contralateral side will all be dilated. So apparently there's a collateral circulation which is going on, so that we are comfortable even if we resect the entire jugular bulb.
That's exactly what you said.
Yeah. So that is important for us to look at the contralateral side and the other dural venous sinuses in addition to looking at only the pathology on the scan.
Correct. That's exactly what he said. So Satish, I know you do balloon occlusion test. Do you really want to dwell on this balloon occlusion test?
Yes.
When do you do it and how do you do it?
Regarding the cross flow.
Yes.
Yeah, Narayan, cross flow, let me, for the audience, cross flow studies are very important once you deal with the tumors involving the carotid artery, so that in any given unfortunate situation, if you need to take a call regarding the carotid, suppose bleed and laceration, you need to take a call of the carotid, block, whatever, you need to have a complete information. This cross flow information, no single investigation can give you 100% result. In spite of the best test, in spite of the battery of tests available for the cross flow studies, nothing is 100%, and still you have a chance of a stroke. So you have to be very careful. Now in our practice, we do take into consideration 2 or 3 investigations together to ensure about a good cross flow. Number one is what you said is a balloon occlusion test. While occluding the balloon, if you see the filling of the ACOM and the middle cerebral from the opposite side, you can assume a good cross flow. But that is not very sensitive. What we add on to it is to repeat this on a hypotensive background. The same test we repeat with deliberate induced hypotension. So in that situation, or normotensive or little hypotensive situation, still if there is a good filling of the anterior circulation, ACOM and the MCA from the opposite side, you can assume that the patient has a good cross flow. Because if you don't do this hypoplastic, which is more hypotensive test, which is more sensitive, in a regular situation, if you find a cross flow is good, and in a post-operative situation, when you block the carotid, if patient goes in some sort of hypotension, the patient may get a stroke. So to increase the sensitivity of the balloon occlusion test, we add on this hypotensive anesthesia, number one. Number two, we take into consideration is a venous phase difference. This is a very, very sensitive test to compare the venous filling on both sides after occluding the balloon and without occluding it, so that you can see the phase difference. If it is more than 2-3 seconds, you can assume that a cross flow may not be very good, in spite of your balloon in a normotensive situation giving adequate cross flow. Number three, that is little adding on to the expense, is using 2 catheters. After occluding the balloon, first you pass the catheter beyond the occlusion site, then occlude the balloon and take the pressure on the closed stump. The pressure which is coming from the opposite side after occluding the blow with the balloon, whatever flow coming from the opposite side, if that stump pressure is more than 2/3 of the given point of systolic pressure, you can assume that your cross flow is very good. This is so important a study to ensure a good or adequate cross flow to prevent a stroke, and no single test can give you. By taking these 3 tests together into consideration, number one, balloon occlusion in hypotensive condition, number 2, venous phase difference, and number 3, the stump pressure, which should be more than the 2/3 of the given point of time systolic pressure. If these 3 tests shows adequate cross flow, we can assume up to 99% sensitivity that the cross flow in that particular patient is good. Otherwise, if you take a call on the basis of a single test, the chances of a stroke are still high, up to 10%, in spite of showing that particular test is showing an adequate cross flow. This is our protocol.
Absolutely. So I think we had a very, very extensive discussion on the preoperative investigations, what needs to be done in the case of glomus jugulare. I hope the points put forth by the panelists are all taken well by the audience without any confusion. And of course, Satish will also talk to you why he prefers the CT scans. Okay. So Sampath, you said you embolize, right? How often, I mean, how early do you embolize, and what is your protocol? You're muted.
sorry, I embolize all my C-class tumors, that is tympanojugular paragangliomas. And the
okay, just for the record, do you embolize? I know of some people who embolize even tympanicums and hypotympanicums. Do you embolize that?
No,
Just
no,
for the record.
absolutely
okay,
no. But there have been situations where the tumors have bled a lot. Some very big B3s have had considerable bleeding when we dissected. But most tumors come out nicely. So they don't need embolization. 98% of the tumors come. One odd case I remember where I wished there was some form of embolization support, but obviously I didn't ask for it. But class C tumors, all class C tumors I embolize. I do not operate on class C1, so it obviously starts from C2. So C2 to C4, all the tumors in my setup get embolized. Now, embolization for me, the earlier the better. So I try to post my cases the very next day, and the longest I've had is 72 hours. So, and even after 72 hours, I had a good bloodless field with embolization. My embolization goes also with my balloon occlusion bar stenting strategies. Balloon occlusion was alluded by Satish sir, and very lucidly so. What I would have liked to add there is also the anterior posterior circulation apart from the cross circulation. So we also check the vertebral artery and carotid anastomosis and see how it works. Anyway, so that's about balloon occlusion. In my cases, anything greater than 270 degree, I offer stenting to all my patients.
We'll come to that, Sampath. We'll keep every answer short. I think we have had really extensive discussions. I see the time is closer to 10:15.
Yes.
To all the delegates, we're going to discuss every point. To all the delegates, we are going to discuss. Please stay on. I know it's a very lengthy discussion, but please stay on, because at the end, the panelists are going to show you some videos and some lovely videos that they have really prepared. Short videos, but I exhort you to stay back. We'll discuss each point.
The reason why I mentioned stenting was if just to complete that, if I'm going for stenting, then my embolization goes along with stenting. So just to complete that sentence.
Okay. All right. We'll come back to that. Satish, you want to describe what you do? You don't embolize. So what do you do?
Narayan,
yeah.
In our clinical practice, we rarely embolize the jugular paragangliomas. For many reasons. Number two, what do we actually achieve with the embolization, and what exactly the embolization procedure, the quality of embolization is? Altogether, these are different things. Number one, to achieve a good embolization, you need to have a good intervention radiologist. You need to have a, embolization till microvasculature level. Number two, we embolize or we achieve embolization only external carotid arterial feeders. See, there are three sources of bleeding in paragangliomas. One is if there are feeders from the internal carotid artery, we do not embolize. Nobody embolizes for that matter. Bleeding from the venous system, we know there are lots of venous sources of bleeding, including inferior petrosal sinus, condylar veins, and all those. We do not achieve anything out of embolization. What we achieve only the arterial embolization, that too the branches coming from the external carotid system. Nothing beyond that. And in our practice, we achieve that sort of embolization that may not be so good as compared to a very, very perfect embolization, but that is quite good by means of following on CT angiogram each and every vessel supplying to the tumor. And then intraoperatively, when you go to the neck, we catch all those feeders and ligate all those feeders to devascularize the tumor, and it works very well. And we have shown number of times in our live surgical demonstration without embolization, and a reasonably good surgical field. I do not say in terms of comparison that how good it is as compared to a very good embolization. Now, coming to a very good embolization, it calls for a lot of things. Number one, a very good intervention radiologist. It has its own complications sometimes if the intervention radiologist is not very good, if there are dangerous anastomosis, if any. Number two, the cost of the embolization. That is again a big factor in our country, where the embolization sometimes costs more than the cost of the surgery itself.
Yes.
So what we have seen in our practice, out of our experience, we do not embolize. And yes, we follow the vessels, and individually we take care of them before handling the tumor, and it gives us a reasonably good devascularization. Even if you embolize to the level best in the world, you cannot do anything to the venous bleeding or the bleeding coming from the internal carotid system, which you anyway cannot do anything to.
Point very well taken, Satish. Thank you. So coming down to the next slide. This is the next slide. Raghu, would you want to take this on? This is just for the junior most audience. I put 2 pictures. Just very briefly, not an extensive discussion, just briefly, why would you want the lower cranial nerves and the vessels under control, and why would you expose the facial nerve? Very briefly.
Absolutely. So basically, we need to secure the great vessels in the neck first before we actually get into the mastoid and also expose the glomus bit. So apparently, it is important for us to identify, have a good neck dissection done, expose the carotid sheath. As you can see very beautifully there, we can see the common carotid, the external carotid artery, the internal carotid artery. Remember, the external carotid artery is medial and internal carotid artery goes lateral. So essentially, there is a turn, the twist that's very important for us to identify. And you can see the 12th nerve above, the hypoglossal, which crosses the bifurcation. And just behind that, beneath that is the carotid sheath. We can find the vagus, a thick nerve, which we can identify just behind the great vessels. And the IJV has been retracted laterally. So we secure all these important vessels in the neck first. And we all know that the posterior belly of digastric is the highway to the neck dissection towards the styloid apparatus. So we also identify just posterior to that, the 11th nerve, as you can see there, that is the spinal accessory. And once all these lower cranial nerves, 10, 11, 12 have been identified, we can dissect further up. We also would see the hypoglossal sometimes higher up over there as we reach towards the styloid process. And as we all know, most of these large type C glomerus jugular tympanicum will also engulf the facial nerve. It is important for us to, as we do the soft tissue dissection, it is important for us to dissect the mastoid tip, expose the stylomastoid foramen, and also identify the tracheal pointer and also the main trunk, the branch of the facial nerve, and may also up to the main divisions. I would also dissect into the parotid fascia and identify the main trunk until the point where the facial nerve is free from tumor. Because sometimes, as we all know, this glomus is also going down to the stylomastoid foramen. It would engulf around the main trunk in the skull base periosteum. We would not be able to find a clear facial nerve sheath. So we want to find the distal segment. And also, we all know that we have to harvest the great auricular nerve prior to this kind of dissection, so that if suppose we need to sacrifice the facial nerve, we would use a great auricular nerve as a graft between the different segments of the facial nerve. So all this amount of soft tissue dissection in the neck, in the parotid, in the skull base, mastoid tip, parapharyngeal space, styloid apparatus, all this needs to be done before we actually get into start the bone work for drilling into the mastoid.
Okay, thanks. Madhuri, this is an anterior transposition of facial nerve. Any comments on the transposition, why it needs to be done? What is the thing you tell the patient before surgery?
As the tumor occupies most of the infratemporal fossa and the facial nerve lies just in the mid of it, it needs to, if we want to do surgery, everything lies medial to the facial nerve. It has to be lifted and taken out of the operative area. So that's why we do the anterior transposition of facial nerve. The few important things to be kept in mind, which are very important, are that once we expose it, as Dr. Raghu was telling, it's stylomastoid foramen, we must expose it beyond its up to its division pes and serenus into the parotid. One thing, keep the soft tissue like connective tissue around the facial nerve in the stylomastoid foramen area, because we have to hold it and we want the vascularity. Also, never expose the epineurium in this area. It should always be covered with fibrous tissue and this connective tissue, and with the non-tooth forceps, we find forceps, we have to hold it. Another important thing is, when we are lifting, doing anterior transposition, we have to do around in the mastoid segment, we do almost more than 270-degree drilling to expose the facial nerve in the mastoid segment. Another thing is, we have to use a sharp beaver knife to separate the facial nerve from the surrounding fibrous and the vascular strands in the mastoid segment. One thing. When we go to tympanic part, we do only this 180-degree drilling and lift it up. We have to use micro-respiratory. We don't use any sharp instruments there. And as this facial nerve will lose its vascularity here, so there's a chance that we may give slight facial weakness to the patient. So we will lift it up to geniculate ganglion. Here we must remove all the bony sharp edges there because we may traumatize the facial nerve at the geniculate ganglion. Another important thing is when I'm lifting, in one of the case, I suffered the loss of this facial nerve. The branches going to the styloid muscle and the postauricular branch, they should be cut, because unless until we cut those branches, we don't get the extra length of the facial nerve, which needs to be taken anteriorly to avoid the stretching. And once I was lifting, I didn't cut those branches, so I got the facial nerve torn here. So this is to be made very important. This part of the facial nerve should be free when we are taking it, this inferior part, when we are taking it anteriorly.
Okay, so point taken is that you have to transpose the nerve from the geniculate ganglion all the way beyond its upper and lower division. If you just stop your dissection at the level of the junction, your facial nerve is not going to be transposed very easily. There'll be a lot of stretch and tension. So you go beyond that and transpose it anteriorly. Sampad, a brief thing, would you think of partial transpositions that some people have talked about, or would you always go for total transposition?
If it's a small tumor, if it's a C2, for instance, I would transpose it as much as it is necessary. So in bigger tumors, obviously, it would go the full stretch. One more point to add on to what Madhuri Madam has just referred to. If we cut the branch of the stylomuscular branch to the facial nerve, it becomes important that we preserve the petrosal branch coming from the middle meningeal artery that supplies the area of the geniculate ganglion. So we have at least two branches, that one and the branch comes from the eye cut that supplies the facial nerve. Two out of the three branches are preserved. So we obviously have to cut the stylomuscular branch to reroute the facial nerve. So as we go around the area of geniculate ganglion, it becomes important that we're not over aggressive and try to be a little safe on the petrosal branch. But then if there's tumor all around, then obviously that becomes a little difficult.
We'll come to that. Satish, anything about partial transposition versus total transposition, your views?
Yes. See, Narayan, first of all, why we need transposition? This jugular bulb is crossed laterally by facial nerve. And when we deal with a tumor, that too so vascular, with the facial nerve coming in between, we need to do something to effectively control the tumor and preserve the facial nerve. By means of transposition, we effectively take the facial nerve to a different region and can control the jugular bulb in the best way. If you transpose, you can control the jugular bulb in the best way, with a price to pay of some sort of facial paresis, because we take away the vascularity from the bed. Now, what do we achieve by means of it? We get a complete control of the jugular bulb, which is unmatchable as compared to the partial transposition, fallopian bridge, or whatever. Now, when you look at the tumors of the jugular bulb, if it is a small one, like Sampad mentioned, for small tumors C1, you can get away with a partial transposition, or in a good pneumatized situation with a fallopian bridge technique working over and above below the facial nerve, you can get away. But if you look at the papers of the revision surgeries, majority of the cases of recurrences are because of incomplete exposure of the jugular foramen. If you do not expose the jugular foramen completely, you tend to leave the tumor behind. This is a benign tumor for which the complete cure is by means of complete removal. That's the only way. By means of incomplete exposure, incomplete transposition, all these are the, something which predispose to a incomplete control of the tumor, incomplete control of the jugular foramen, and one may tend to leave the tumor behind. Number one. Number two, the control over the carotid artery. See, by means of limited transposition or fallopian bridge, you cannot control the carotid artery anteriorly so effectively as compared to the transposition situation. For any given situation where the carotid is involved, I would always go ahead with the anterior transposition rather than doing all these, maneuvers to risk my carotid in terms of complete tumor removal. So you have to take into consideration all these things.
Thank you. So the view for the junior colleagues is please go and do a complete transposition. Yes, partial transpositions have been described, but I think that's something which is fraught with a lot of risk as well as incomplete removal, and it's very difficult to maneuver on every side and take off the tumor without injuring the facial nerve. So anterior transposition for all C-type tumors is what is generally proposed by most. Okay. So coming down to a facial nerve which is involved with the tumor, Raghu, you want to add something? We talked about tumor around the facial nerve, but a tumor completely involved. Apologize for the quality of this. This is a very old picture.
Yeah, so if the nerve is involved by the tumor, I think we should sacrifice that part of the new tumor and along with the nerve. So we should find at least a virgin nerve on both sides, which is not involved by the disease. And ideally, we can put a great auricular nerve graft, cable graft with a microneural anastomosis, with a venous venous endothelium or probably a temporalis fascia and tissue glue. That is what we usually do. But apparently that part of the nerve which is involved by the tumor is probably gone. So I don't think that nerve fibers are going to rejuvenate
You will graft it, correct.
the tumor out of the nerve.
Correct. Okay.
Can I add?
Yes, Madhuri, go on.
One thing regarding facial nerve involvement, it has been divided into 3 grades. Grade 1 is when the tumor is not involving the epineurium, it is keeping a bit of, there is a gap. So easily we can remove the disease not touching the facial nerve anywhere. Grade 2 is when it is involving the epineurium. So we can separate the epineurium and keep the facial nerve intact when the perineurium is, free of disease. But that step is to be taken once all the tumor is out. We have done anterior transposition. Once all the disease is out, then we will separate, peel off the epineurium from the rest of the facial nerve. But once this tumor is involving beyond epineurium into perineurium and the nerve fibers, then definitely that segment of the nerve has to go with, of course, facial nerve grafting or extensive disease, facial like motor nerve transfer. So many techniques are there, but these 3 grades are to be kept in mind while removing the disease from the facial.
Okay. So this is a picture. Satish, you want to just talk about the anatomy in just half a minute? I think we are running late with the panel. We have got a lot of points still to discuss, but very briefly, anything that you want to talk about the jugular foramen area?
Okay. So jugular foramen is so strategically deeply located in the temporal bone, we all know. It is located inferior to the medullary cavity. It is located deep to the tympanic bone. It is located deep to the facial nerve, and this jugular foramen is basically a continuity of the sigmoid sinus which enlarges to the jugular bulb, and from there the venous drainage is continued through the jugular vein IJV into the neck. So this jugular foramen has relationship with the various critical structures. Like for example, anteriorly what you see in the picture is the internal carotid artery in close relationship, though it is very well separated by the bone in a normal situation. Medially, the relationship of the jugular foramen or the jugular bulb has many important structures. Medially is the cranial nerves. All the cranial nerves from the cranial cavity, they pass deep to the jugular bulb. They take a 90-degree turn medial to the jugular bulb and then pass on to the neck. 9, 10th and 11th particularly. And the 12th is being separate, being deep to the jugular bulb through the occipital condyle coming separately into the neck. So once you deal with all the tumors in the jugular foramen, you need to have complete understanding of the critical structures all around. The carotid artery anteriorly, the structures medial to the cranial nerve, the occipital condyle medially, and then in the medial wall is the dura of the posterior cranial fossa. The most of the tumors of the, like we are talking about the tympanic, the jugular paragangiomas, they arise from the dome of the jugular bulb. Then they proceed into the lumen of the jugular bulb. As long as they are in the lumen and not involve the medial wall, the cranial nerves are separate, because cranial nerves pass deep to the medial wall of the jugular bulb. Now, once the tumor pass deep to the medial wall, once they involve the medial wall and pass into the intracranial cavity, the cranial nerves are almost always involved. So the involvement of the cranial nerves are important, and we need to understand this anatomical relationship to the medial wall. As the cranial nerve passes, all these cranial nerves pass deep to the medial wall of the cranial, the jugular bulb. Similarly, the carotid artery, the cochlea and other structures are above, and in continuity behind is the sigmoid sinus. So all these are the anatomical structures we need to keep in mind once we, deal with the jugular paragangliomas and the anatomy of the jugular foramen.
So the juniors, very junior people who are actually, this is why you require control of the internal carotid all the way from the neck going down to this area around the eustachian tube, and sometimes even the petrous, the horizontal segment, and so on and so forth. Okay. Similarly, the IGV over here, Satish has mentioned very nicely, when we take the jugular vein, internal jugular vein out, we leave the medial wall of the jugular bulb intact wherever it's not involved, because the nerves pass deeper or medial, much medial to the medial wall. So only the lateral wall of the internal jugular vein is involved. And of course, all the details you can know and see in surgery, but this is the anatomical picture that you need to keep in mind. Coming down to internal carotid artery, Sampath, maybe you could answer this. You can see some amount of tumor on the carotid, some part of tumor dissected off from the carotid. How would you assess the involvement of the carotid, and what would be your strategy? You're muted.
So involvement of the carotid for me is always a preoperative analysis. I would try to get maximum information preoperatively by means of an MRA. That's why I would like to do an MRA for all my cases. So the carotid is infiltrated beyond, if it's infiltrated, which means the carotid is irregular, or if the bulk of the tumor is more than 270 degrees around the carotid, for me, then it is a critical issue, because obviously we have to look at total tumor clearance, as Satish sir alluded to it. It's a benign tumor, and the only cure is total tumor clearance. So no point in doing a big surgery, 10, 12, 14 hours, and then eventually leaving behind tumors which will have to eventually come out, will have to be addressed sometime in the future, maybe 3-4 years later, but it has to be. So total tumor clearance is the order of the day. And if that has to be achieved, carotid has to be planned effectively. So irregular carotid greater than 270, I would advise stenting. In my practice, about 50% of the people take up stenting, 50% opt out of it due to cost factors. But that's something that I offer. Now, if in a case where the situation is like this, where there's tumor around the carotid, one needs to peel it out bravely but very carefully. The part which is around the carotid canal, the carotid foramen, what you showed in the previous pictures, is a little critical, because that is where there are fibrous bands along with the tumor. The tumor has fibrous bands, so as we dissect, it becomes difficult for us to identify whether it's tumor or if it's a fibrous cuff around the carotid. That exactly where your pointer is. So that tissue sometimes is a matter of confusion. Higher up, what happens is the periosteum kind of gives it, so there's no adventitia. So the periosteum itself is adventitia. So when you're drilling out bone, you take out that tumor by drilling out bone. So as you drill out bone, you are practically on the carotid. So you'll have to become, and obviously these pieces bleed. Some of them, if not embolized properly, bleed as if it's bleeding from the carotid. So over a period of time, through my experience, I've seen to be less scared of the bleeders around the carotid, be a little more aggressive, but then be delicately so. And it's that part you see just under the cochlea as the genu goes, if you're trying to preserve the cochlea. So that part is where it gets more and more difficult. Then you'll have to decide whether you want to drill out the cochlea. For drilling out the cochlea, then obviously, you're endangering the exposure of the internal aortic canal, which means CSF leak. So these are the issues. Yes, but with using a very fine fish hook, we could peel the tumors out slowly, bipolar peel, get a plane and go ahead. But yes, this requires experience. So that part which you're showing there, where you have nicely peeled the carotid and going up, that requires a good amount of experience if it's not stented or if no other intervention has been done pre-operative.
Madhuri, what's the risk if you peel out the adventitia of the carotid? One is you're staying in the layer of this periosteum, right? What happens if you peel off the adventitia of the carotid, or if you dissect the carotid too much?
Yes, chances of injuring carotid directly. So that is a big complication we may have. So wall may get, ruptured, and then there will be a bleed. So of course, the stenting is the only way to save us from that. But the area which you showed, it really needs a lot of experience to be going there into the right plane, protecting the artery. So in case, as he's saying, adventitia is also involved, definitely stenting is the only way we can protect our carotid.
Okay, Satish, anything to add on this? How do you manage aneurysms, or even, this is of course showing plaques, but it is just representative of how you would dissect the tumor off it. You want to add anything quickly on it?
Yes, Narayan. See, a lot of things have already been described by Sampath in a beautiful way.
Yes.
But just to add on, what you are asking about the subadventitial dissection.
Yes.
See, subperiosteal dissection is something which is required most of the time because tumor involves the periosteum of the carotid, and you can go underneath that and protect the carotid, and you can even transpose the carotid away from the tumor for time being. Now, once the adventitia is involved, you can think of subadventitial dissection in the vertical course of the petrous carotid, not in the horizontal, because horizontal petrous carotid doesn't have adventitia, and there are chances of laceration even if you try to do that. So in the vertical course, still you can attempt subadventitial dissection under microscope very, very carefully with your instruments, but you have to be careful to prevent laceration of the carotid. In case lacerations happen to occur, as I already mentioned, in tumors involving the carotid artery, we do a complete study regarding the cross flow. So in any given unfortunate situation, we can take immediate call on the table. Number two, in petrous carotid with the infratemporal fossa exposure, when you remove the tympanic bone and everything and make the temporal bone in continuity with the neck, you have ample of exposure to deal with the carotid laceration. In our practice, 3 times when inadvertent laceration of the vertical petrous carotid, we could suture it very well and get away from stenting and all these things. 3 times we have done by putting the bulldogs on either side immediately, and with a needle you can take a suture onto the carotid and get away for need of the stenting and all that. In situation of lacerating the carotid, in situation of the complication once you injure the carotid, I'm not talking about the pre-operative planning of stenting and all that. That is a different thing, and that is required in case your tumor is involving the carotid, as the tumor is involving the wall of the carotid, the revision situation, any irregularity in the carotid, then you can plan of stenting rather than sacrificing the carotid to the cross flow is not good. That's a different situation. But you can deal with the carotid intraoperatively by various means, by means of decompression, subperiosteal dissection, subadventitial dissection, like you're talking about. If you are working deep to the carotid at the level of the petrous apex or something, your tumor is involving the petrous apex, you can mobilize the carotid temporarily, elevate the carotid and drill away the bone underneath and get away by complete tumor removal and replace the carotid back into place. So there are many ways to deal with the carotid, and it depends upon how the tumor is involving it.
Okay, thanks. So we still have a lot of slides. I know we are running out of time with the 2-hour panel. We still have the panelists to show their videos. I'm going to just quickly run across because there are still some points we have not touched.
There are a few questions from the chat box from the audience.
Yeah, I saw that. I think we have covered most of it except embolization part, what material is used, but I think I won't dwell on that. There are a lot more important things to dwell on. Okay, just quickly, Raghu, patient, young patient with an intracranial extension. What is your mode of, what will you advise this patient?
So I will get my neurosurgeon involved in the case. Apparently, this is a cranial extension of the glomerus, which is possibly going into the posterior fossa. You can actually see that it is going into the CP angle, probably through the internal canal involving the cerebellum. So it will require a combined approach. Apparently, it would be a posterior fossa craniotomy along with a transmastoid approach. We'll have to
a quick interruption, Raghu. Would you remove all this in a single stage, or would you remove it?
It all depends. So with the scan alone, we will not be able to decide. We will have to do further, MR. This is MRV, which is basically showing that apparently the tumor is quite big. I think it would be apparently good for us to have a combined approach with the neurosurgeon coming in and dissecting the intradural extension as much as possible. So I think it is not necessary that we need to stage the procedure.
Madhuri?
I think I should be staging the procedure because I want this tumor, this is so close and adherent to the, it seems to be adherent to the brain tissue. So in 2 stages, for that will devascularize the rest of the tumor. So we can avoid CSF leak also by doing it into 2 stages. With the chances of CSF leak, because we are connecting neck and brain, so chances of CSF leak are there in post-operative period. So for me, it is to be 2-stage surgery.
Narayan,
Yes, Satish.
can I add something?
Yes, yes, absolutely. Go on.
What Madhuri is saying is a good strategy to stage the tumors with intradural extension, particularly large intradural extension, because you don't want to deal with the CSF at the same time, because there is no tissue to contain the the large neck spaces from the temporal bone. Now, in the given picture, what you have shown, the given patient, I don't see any large intradural extension. You can see, what you see is a in continuity posterior fossa extension from the medial wall of the jugular bulb. It doesn't look like a big one. For such a case, I would do the same stage. I would, after removal of the extracranial tumor, after removal of the jugular foramen tumor, I will devascularize the dura, open up the dura, and remove for this a centimeter or so intradural extension at the same time, and plug with a muscle patch, and then packing with the complete cavity with the fat. So this small intradural extension, I will do same stage. But yes, for the large dural extension, intradural extension, like Dr. Madhuri said, definitely staging it a good way for many reasons. Number one, you remove the extracranial tumor and devascularize the tumor very well. Once it heals, once the subtotal petrosectomy, your neck space, everything heals up, after a couple of months, you can enter into the cranial fossa from a different route, from a virgin entry. With a devascularized tumor, you can remove in a very, very simple manner. You can go transsigmoid, you can go retrosigmoid, whatever, and remove this intradural tumor very easily. So that adds on to the safety as well as surgical ease to the surgeon once you have a large intradural extension. But for such a small intradural, I won't think twice and remove it at the same stage.
Yes,
to summarize, small intradural extensions can be removed. Large intradural extensions do it in second stage. The reason is primarily CSF leak, and you have to really plug this because you have to plug the dural defect, because you really don't want the CSF coming out. If it comes out, you don't have an airtight cavity to really seal it, and you're in a deep mess. So that's the underlining message in this. On the other hand, of course, this is a picture taken from Soman Curtin, not my patient. But if you see this patient has an intracranial extension, assume, this is just for theory, I put this for debate. So assume this is a 70 or beyond 70-year-old subject having an intracranial extension. Would your strategy change? Maybe Raghu or Sampath, maybe I've not asked. So Sampath, would you change?
If it's a 70-year-old subject, I would assume that this patient would have had the compensated low cranial paralysis. There's again not much of tumor in the middle mastoid. So if bleeding from the ear is not a problem, I would wait and scan. And yeah, if it's a fit 70-year-old, I would go ahead and operate. Remove this as much as possible, obviously not going intracranial. What I do is I go around the curvature of the dura using the navigation. I make sure that I'm very close to the dura, and I use coblation over the dura, trying not to puncture the dura, so leaving behind a small residual on the dura, which is the dura itself, dura and the tumor together. And it's very important to see the difference between this scan and the previous one. If you see, I completely agree with Satish sir that if you see the previous scan, you see that there is a small amount of CSF space between the tumor and the brain. So here we don't have that space. So here it's clearly intradural kind of brain extension, whereas that could easily be plugged out. Even being aggressive on the dura, if there's CSF leak, that can be plugged. So that's a straightforward situation. I would go here, but in this case, definitely stage. I would go very close to the dura, leave behind the small sheath, removing most of it.
Satish, agree, disagree?
100% agreed with what Sampath said.
Okay.
And like Narayan, you mentioned 70-year-old. What Sampath said is absolutely what we are following, that you have to have a conservative approach unless the patient has some difficult symptoms or difficult issues with the tumor. Most of these tumors are indolent, they're slow growing. You can periodically monitor with the MRIs. If the tumor is growing and giving any pressure symptoms, then you have to think of it. If it is growing and not giving pressure symptom, you can think of radiation to contain the growth of the tumor. You know, we deal with such tumors aggressively, most aggressively, if the life expectancy of the patient is more than 25, 30 years.
Yes.
Then the situation would have been a different altogether. But 70 years with this kind of the tumor, with no symptomatology, no tumor in the middle ear and mastoid, you can think of observation with periodical MRIs. And if it starts showing some growth, you can think of radiation therapy.
Yes, perfect, sir.
Perfect. So everyone agrees. So this picture is again taken from Professor Mario Sana's article, which has been mentioned down here. Vertebral artery involvement. I know Satish has got a patient of vertebral artery involvement. Satish, just a quick thing of when would you do and how would you manage this vertebral artery, and what is the extent of tumor removal you'll go for? Just a quick word on it.
Yes. So Narayan, vertebral artery involvement is one of the most complex aspects of the paragangliomas, particularly jugular paragangliomas. When they extend posterior-inferiorly, medially, they extend to involve the occipital condyle and the vertebral artery. So with such extensions, I mentioned about the case we recently dealt with, had a vertebral artery involvement, complete encasement of the vertebral artery from all around. We did the angiogram, cross flow studied, and there was good filling from the opposite side. Even the posterior cerebellar artery was filling from the opposite side very well. And we finally took a call of, the coiling the vertebral artery completely and remove the tumor completely. But that was a straightforward situation, as the tumor itself clogged the vertebral artery, compressed the vertebral artery, and given the collaterals very good. Otherwise, involvement of the vertebral artery is very, very complex. You need a very good exposure if you need to deal with small involvement of the vertebral artery and around the vertebral artery. What you need is extension of the infratemporal fossa approach inferiorly, and that is infratemporal fossa approach D, when you add on far lateral approach to it. In far lateral approach, you can mobilize the vertebral artery very well. You can coagulate the plexus around the vertebral artery very well and devascularize the tumor, and you can remove the tumor. In small involvement of the vertebral artery, in massive involvement of the vertebral arteries, you have to think twice before going ahead with anything. The case I described was complete encasing with good collateral flow, was a different situation. Otherwise, encasement of the vertebral artery to us is a contraindication for any, radical surgery. I would remove the tumor from everywhere and shave off from the vertebral artery and observe post-operatively for any growth. In case start showing growth or showing significant growth, we'll take the help of radiation post-operative.
Thanks. Okay, Madhuri, a quick question to you. A young boy, you can see this boy is only, sorry, I'm going back. This is just a young boy of 21 years. You can see some neurosurgeon has attempted surgery. I'm just giving you one cut to talk on debate on the residual tumors. Someone has attempted a neurosurgery on this, and you can still see a lot of residual tumor. Young boy, what is your management of this patient?
Definitely revision surgery, infratemporal type, fossa type A, or whatever the rest of the cuts and MRI shows. So we can very easily go. He's a young boy. He's a long life to live. So we shall be totally excising the tumor.
Okay. What about this post-radiotherapy, Raghu? Radiotherapy, given a lot of inflammation, post-radiotherapy, such a patient comes to you with a residual tumor. What would you advise?
So that's right. So post-radiotherapy is a different ball game. Apparently, we don't get clear planes. There'll be a lot of adhesion scarring. But probably one good thing is we may not have that amount of bleeding as it would seen in a virgin glomerus.
Would you attempt surgery in this case?
I'm not very sure, because the scans show that the tumor is around the internal aortic canal, and it's probably infiltrating into the CP angle. So as you said, it may be post-radiation edema. We're not able to delineate clearly which is tumor, which is the edema. I would lead to probably do more scans. I would see for an MR angiogram, MR arteriogram, and a venogram, and then see which is residue, which is post-radiation tissue.
Okay. Coincidentally, in the chat box, there's a question: what is the maximum size of intracranial extension we can devascularize and incise and remove in the same stage? That's by Dr. Palniyappan and Trichy. Maybe anyone? Madhuri can take that question.
So if it is more than 2 centimeters intracranial, adherent to the brainstem, then we shall, what is the exact question?
what is the size of the intracranial extension that you would remove at a single stage?
It should, if it is more than 2 centimeters, then it becomes a bit difficult. So we can shift over to second stage. Otherwise, up to 2 centimeters, and then we can devascularize in the same stage as Satish was telling. Keep wetting, keep cauterizing the dura, and keep removing the tumor.
I'm sorry, that came in the chat box just now. Anyone else has any views on how to manage this patient? Any differing views?
It's a 50-year-old female. So I would operate this lady because 50 years is young. It's something that, see, I would not opt for wait and scan, because then we are losing 5 precious years. 5 years later, she's 55, and then 5 years later, she's 60. And then we are left with a fairly big tumor when she's 60ish, and then that would obviously cut short her lifespan if we don't do anything about it. So considering her age, 50-year-old female, I would operate. Yes, it's a difficult situation. Internal canal involved, not too extensive by Glomerus standards, I would say, definitely resectable. But yes, she would lose a facial nerve in this case because there's clear intracranial involvement, and it's very difficult if there's a glomus, if there's a paraganglioma in the internal meatus segment of the facial nerve. I would say very difficult to assure of a total clearance, although it can be tried, attempted. With that having been counseled to the patient, I think we can go ahead and remove this.
Okay. So let me quickly, go on to just a quick thing. I want to end this session quickly so you can show your things. Radiotherapy, just a quick word, maybe Satish. These are just things, but just a quick word on radiotherapy.
Yeah. So Narayan, regarding radiation therapy, radiation therapy is never a cure for the paragangliomas. Radiation therapy is basically inducing the fibrosis in the vessel supplying the tumor. Some sort of fibrosis, arteritis to contain the tumor growth. It is not a cure to the tumor. So it should be judiciously used in certain situations. You have mentioned in the slide many of the important situations. To me, it is never a primary treatment for a paragangliomas unless it is an elderly patient with intact lower cranial nerve function and the tumor showing some growth. You have already mentioned on this slide. So radiotherapy is reserved for all these situations you have mentioned, not as a primary tool to treat the paragangliomas.
So can I add few things?
Yes, Madhuri.
Radiotherapy is not Satish is absolutely right. It does not work on paraganglionic cells itself. It does not work on bigger vessels. It only, narrows down the AV stunting, AV shunt, and this enteritis and arteritis things. It does not work basically on the main paraganglionic cells. So it is just causing fibrosis and narrowing of the vessels and not actually treating the condition. So it is only for the few cases what you have mentioned here.
Fine. So, Vijay, if you're around, I think I had 1 or 2 more questions, but I'm not going to go on to that. Okay, I'm not going to go on to carotid body tumors and other things. The panelists, of course, here have some videos to be shown. If your time permits, can we ask them to show their videos? I know
please,
2 hours, but people who are interested can stick around and see their videos, right?
Yeah, almost 9.
Because we have covered a lot in our panel discussion. But just to drive home points, can we go ahead?
Yeah, please. There are almost 940 viewers.
Oh, fine. That's lovely. I hope they really enjoyed the discussion because we had so many panelists giving such fantastic views, and we tried to bring out everything possible. Thank you all the viewers for being around and sitting with us till 8 o'clock. We were given 2 hours, and I really wanted to finish this panel in 1 hour 15 to 20 minutes. But having such knowledgeable panelists really pushes our time limits beyond some things. You have seen varied opinions, and each one has a scientific reason for those varied opinions. But the idea is they've all given you their reasons for how to manage things. So very quickly, Raghu, do you want to go in and show your video? Just very, very fast, all of you all, okay?
Sure. Okay. So I'm just sharing my screen. Yes. Hope you're able to see my screen.
Yes, go on, Raghu.
Right. So basically, I'm just presenting a case of C1 jugular tympanicum. So this was a 39-year-old banker, a lady, young lady, who presented with right ear fullness, hearing loss. She had an ominous sign of recurrent ear bleeds for the last 6 months with pulsatile tinnitus. She had normal facial motor function, no other cranial neuropathy. no neuro or ophthalmic deficits, no other neck swellings, and there was no obvious family history. So apparently this was the autoendoscopic picture, and this obviously shows that there is definitely a vascular mass abutting the middle ear. And these are the scans. So very classical case of glomus jugular tympanicum, arteriography and venography. And this showed a vascular lesion in the right jugular foramen with erosion of the bony margins of the jugular fossa, erosion of the carotid jugular spine, disease going into the middle ear cleft and mastoid. Apparently this was pretty much a case which we had to operate. So as per our institutional protocol and from my experience having trained in skull base in the UK, we always embolize. Of course, a C1 lesion requires embolization for better amount of vascular control during surgery. And apparently we did this 48 hours post embolization after confirming that there was adequate collateral carotid and vertebral circulation. So just for the juniors among us, the younger colleagues, there are 7 important steps to this surgery. Basically, first we work from the neck. We secure the great vessels in the neck. But remember, we do not ligate the IJV in the beginning because apparently it is going to induce a venous congestion and collateral dilatation from the petrosal vessels, which will cause the vasculature increase and the bleeding intraoperatively go up. So we work up our way towards the carotid sheath up towards the styloid process to expose towards the carotidojugular spine. Then we dissect the sternomastoid from the skull base periosteum, extract the stylomastoid foramen, track the facial nerve into the parotid fascia up to the main divisions. Then we do a blind sac closure. I also rotate a temporoparietal muscle flap, which I can use to rotate into the mastoid cavity. This also helps to secure the skull base from the neck. Apparently, if suppose there is an intraoperative CSF leak, I can use this as a muscle plug also. So once all the soft tissue work is done, then I do the radical mastoidectomy. Of course, we do a eustachian tubal plugging. And once all the mastoid bone around the facial nerve and the sigmoid is exposed, then we have to proceed with the anterior transposition of the facial nerve. And then we also perform a sigmoid sinus compression or obliteration. It's actually a compression rather than decompression. I perform an extra luminal decompression of the sigmoid sinus rather than opening the lumen and plugging it, and this which I have learned from the UK. And after that, we go on to the main tumor removal. So remember that before we actually get into the tumor, we have a lot of work, both of soft tissue work and bone work to do. And apparently the entire tumor dissection follows the internal carotid artery pathway, as which was clearly explained by the other eminent panelists. So I have a small video, just again to highlight for the junior colleagues. This is an extended postoral C-shaped incision. Surface marking for this is apparently 2 fingers above the ear. The first finger is the root of the zygoma. The second finger is in the squamous temporal bone, the middle fossa. 3 fingers behind the ear. So first finger is the mastoid. The second finger will show the sigmoid, and the third is retrosigmoid. So you want to have enough access behind so that we can reach a retrosigmoid to dissect the sigmoid out. And inferiorly, 2 fingers. First is the mastoid tip, and second will be the area where the jugular vein goes up and finds its way into the jugular foramen. So we also give a leeway on the neck to identify the great vessels in the neck. So all this dissection can be done through this extended postoral classical infratemporal fossa incision. So first thing is surface marking, good amount of infiltration. So I take a thick flap. So this is basically from the skin, subcutaneous, soft tissues, and the postauricular muscle. We need to extend the incision forward and make sure that we have enough soft tissue for the blind side closure. Once that is done, primarily we start from the neck. As you can see here, the carotid sheath is being exposed. I'm already on the bifurcation of the carotid, and this is the hypoglossal nerve going forward. And once that is done, we identify the internal carotid and the external carotid. So we ligate the feeding branches. In this particular patient, there was a lot of feeders from the external carotid system, especially the ascending pharyngeal system. So here you can actually see the external carotid, the internal carotid. You have the jugular vein retracted, and this is the hypoglossal. So the further dissection to identify the vital structures in the neck and securing their vasculature and taping them is important. So we identify the external and the internal jugular veins, and also the external jugular vein is sacrificed, greater auricular nerve is harvested, and we put tapes along the vital structures in the neck. And once the vascular security is achieved, then we dissect the carotid sheath upwards. So there you can see the vascular tapes coming in. So I dissect around the carotid and identify the internal carotid and make sure that we have taped them adequately, preserve the 11th, 10th and the 12th nerves as we go along. As you can see now, that's the 11th nerve, the spinal accessory crossing the IJV, and in front you can see the 10th nerve. So we tape them as well. So once we have secured the lower cranial nerves, the IJV and the carotids, then we are all secure to go up, dissecting towards the styloid apparatus. So then we dissect the posterior belly of digastric, go into the deeper planes towards the styloid apparatus. And to get better exposure towards the carotid jugular spine, I've removed the styloid apparatus along with its muscles. So we don't have any bony hindrance towards dissection at the jugular fossa. Once all that is done, we come to the neck and the upper part of the neck, close this down and then go into the ear. There you can see I've done the blind sac. I've lifted off the soft tissue and elevated a bit of the parotid fascia. This is the entire mastoid bone, this mastoid tip being delineated. I'm speeding up the video so we can see faster. So here you can actually see that I've done an extended radical mastoidectomy. There you can see that sigmoid plate is exposed. This is the tegmen and the dura. The ossicles are being removed. And this is the glomerus tumor looking at us. So that is the area where the tumor passes. Then once we have extirpated the mastoid cells, removed the tympanic membrane and the ossicles, so we have the entire glomerus seen clearly in front of us. So that is a tumor that you can see in front, filling up the medial cleft. So then comes the important part, identifying the facial nerve. So once we are able to delineate the first genu, this I am trying to establish by identifying the stapes head, and this is the stapedius tendon. Of course, remember, glomerus is a bloody surgery. You would have blood, and you would have to learn in the field of blood. So apparently, you don't have to wait sucking; it's wasting time. So we have to work as there is a continuous ooze from the tumor. So there you can see that this is the first genu, geniculate ganglion, dissected forward. Then you have the second genu coming in. This is a pyramidal process just in front of the suction, and we are dissecting towards the vertical segment, exposing almost 2/3 of the facial nerve. The facial nerve in this particular case was not involved by tumor. The patient had normal facial motor function. So we actually got away with it in this case because it was a very well pneumatized mastoid. So we did not have to transpose the facial nerve anteriorly. We worked both in front and behind. And this was a C1 tumor isolated in the jugular foramen, going anteriorly up to the carotid jugular spine. And we were able to mobilize the vertical segment of the facial nerve into the parotid by taking off the skull base periosteum in the mastoid tip, and by which we were able to work in front and behind the facial nerve. So there you can see that the facial nerve is fully exposed up to the xylomastoid foramen, and it exists in the parotid. Here and then we move on to the sigmoid sinus. Here we delineate almost half, the external half of the sigmoid sinus, and I do an extraluminal compression of the sigmoid sinus by using muscle plug, Surgicel, and bone wax. Apparently, the previous technique was to open the lumen and then plug it, but apparently there's a lot of blood lost, and from training abroad, I have learned that this technique works better. So we need to identify the sinodural angle as the sigmoid ascends intracranially, and identify the dura and the sigmoid lining, and adequate compression extraluminally help to seal the lumen. So there you can see I'm using muscle plug to seal off the Stitley's angle. Using a bit of Surgicel and then bone wax definitely helps to seal and compress and gain a good amount of compression and seal off. The only problem is sometimes you can have the petrosal veins which can open up and bleed by retrograde blood flow. So we got to be careful. And then we go forward to dissect the tumor itself per se. Initially, I remove the tympanicum part of the tumor to expose the promontory, work around the eustachian tube, then try to identify the jugular bulb and the internal carotid artery in front. In this case, as I said, this is a C1 tumor, so there was not much of disease going into the carotid. So we were able to dissect most of it. Gently using bipolar cautery and irrigation, I was able to seal off, and this is the jugular bulb coming up. There was a bit more of bone here, which I had to drill. I'm just speeding up the video here. There you can see this is the hypotympanic region below the cochlea, and the tumor slowly comes off piecemeal. by periodic cautery. So rest of the tumor was dissected out with more diamond bud drilling and bipolar cautery. Finally, we sealed this up with some Surgicel, speeding up. So that is the last bit of the tumor coming out. As you can see, the end of the surgery, the bleeding is reduced, vascularity is come down very well, and you can actually see that after sealing up the sigmoid and the collaterals also come down. Essentially, you can dissect the piecemeal bit of the tumor on the jugular fossa without any problem. So yeah, then there's a multi-layer closure. We use abdominal fat, which has good turgor to seal off the mastoid cavity. Use some temporalis fascia, then rotate the temporoparietal muscle, and we keep a drain in the neck, and we do not leave any drain on the mastoid. So apparently, mastoid is completely sealed off in multi-layer with a blind sac. A tight compression bandage is given, and the neck drain stays there for 2 to 3 days. So apparently, that's pretty much the procedure that I was talking about. So learning points from, of course, from the eminent panelists, we've all understood that we have to understand the pathology correctly and stage it correctly. We know that left alone, this disease is going to progress, causing cranial neuropathy, intracranial complications, thromboembolic events. So it needs coordinated multidisciplinary input. And operative principle is to remove the tumor in entirety, preserving the integrity of the cranial nerves. And we have to reanimate the nerve if it has been sacrificed. In general, long-term outcomes are not uniform. We cannot generalize. It's difficult. We have to follow case by case. And if disease recurs, options are limited. Thank you for your patient listening.
Thank you, Raghu, for a fantastic presentation. Quickly on to Madhuri. Madhuri, are you ready?
Thank you.
First, he has to put off his, then
he's stopping his share.
Done.
Done? Now I can share mine. So I'll try to be quick.
Nice presentation, Raghu.
Thank you. Thank you, sir.
I'm sorry I'm rushing you people up, okay?
Yeah. I had to speak.
I'll go very fast because of the limited time. So this one case, I'll take one small clipping of glomus tympanicum and one of the glomus mesoidalis, as jugular has already been taken up by Dr. Raghu. So this is glomus tympanicum, right side filling the middle ear cavity. And this is the axial contrast enhanced T1 with fat suppression. This is strong enhancement in the middle ear only. So already been talked. This is the video for that. Right side, post-oral route, meatotomy already given, meatotomy already done. Now I'm lifting the tympanomeatal flap. As Dr. Narayan was telling, we usually tend to take off whole of the cuff of the skin of the extraoratory canal because it keeps coming in the way in the when we are doing drilling. So I'll be using it later on once the tumor is out. So I'm trying to save as much skin as possible because all this skin is normal. Bipolar cautery is a very good tool. Now this is coagulation, which I use on the surface of the tumor on the lateral side. So it shrinks the tumor a lot. Then when it is going in the, towards eustachian tube or retrotympanum, then I tend to use bipolar cautery more. So keep separating, keep bipolar cauterizing, and keep lifting it off the ossicles. I have already done canalplasty in all the directions so as to expose the tumor in all in whole of its circumference. As Narayan showed in the start, keep pulling, keep doing bipolar cautery, keep pulling, and keep using Surgicel or cotton balls or gel foam, whatever gives you control over the bleeding. And as Dr. Raghu is telling, it is a bloody field. You have to learn to do surgery with this much blood around, but try to make it as clean as possible. So once the bleeding is controlled, it becomes very easy to take it out. You can keep pulling it out from the retrotympanum or eustachian tube opening because it is not attached there. Once it's out, we must check into the cortical area, this bony areas where the tumor might have been left. So we can do a diamond drilling there. Now this small part of it is left still in the attic region. Just take it out, make the middle ear cavity absolutely clean and clear of the disease, because as this is a benign disease, every bit of it should be out. So the ossicles are okay. I have done a bit of drilling in the epitympanum. So I'll be reconstructing it with a piece of cartilage. So just a piece of cartilage, because it should become like a normal middle ear and external artery canal. This is the fascia I've been using, and then putting the skin which I had used. They had saved in the start of the surgery, and bit of split thickness skin graft has also been. This is the skin graft I have harvested, and the limited skin I had harvested in the start of the surgery. So that way it becomes closest to now. This is the skin I had harvested in the start of the surgery. Okay, now coming to glomus tympanica, mastoidalis. Now this was a case, second case, where somebody had taken the biopsy previously. The patient came to me, I could see this tumor occupying the antrum, whole of the mastoid. Internal layer is absolutely normal. Facial horizontal part, everything seems normal. But in the vertical part, it seems the facial might be found exposed. This is the whole tumor filling up. The important thing to share here is, as Narayan was showing, this is glomus mastoidalis because the internal carotid arteries has intact wall, and the jugular also. And there is no destruction of this jugulo-tympanic, jugulo-carotid crest. This can be compared with this picture. Here you can see the complete destruction of the jugulo-carotid bony spine, where it was not visible in the previous. The carotid is intact, jugular is far behind. So this is a case of glomus mastoidalis. But here the patient had presented with, it is a delayed presentation, so had SN loss also. So I finally choose to do total petrosectomy in this case. This is the left side of the patient. So again, segregating it using coagulation in between. Keep separating it from the surrounding structures. It does take a lot of time to create a bloodless field and keep doing the surgery. This is canal wall down mastoidectomy in progress because it was involving whole of the middle ear and the mastoid cavity. Bulk of the tumor is out, but still there is a lot of tumor there. Canal wall down mastoidectomy, every bit of the tumor has to be out. But in this case, the whole tegmen was eroded and the dura was exposed. So finally, what I chose was, after removal of the tumor, I did complete cul-de-sac closure and obliteration of mastoid cavity, as patient already was suffering from profound sensory neural hearing loss. Oh shit, sorry. So all the disease is out now. I am creating holes in the bone around so as to fix up the temporalis flap and the sternocleidomastoid flap to be used to obliterate the cavity. Now fat is being used to obliterate the middle ear and mastoid. This is the post-oral sternocleidomastoid flap. What I do is I learned it from Hormani sir. width of the muscle is converted into length by splitting it in the middle. This is the sternocleidomastoid flap, which fills the lower part of the cavity. And this is the temporalis muscle, which is again, width has been converted into length, and the whole of the cavity can be filled with this. This is just steps of cul-de-sac closure, because it was decided per-operatively that I'll do this complete obliteration of the cavity. So this is the second layer of the cul-de-sac closure being separated, musculoperiosteal flap. The skin of the extraordinary canal is being separated, everted out and used as first layer of the cul-de-sac closure. And the second layer is being, suturing the musculoperiosteal layer with the surrounding soft tissue and the cartilage. That way we totally segregate the extraordinary canal from the mastoid cavity. The whole of it is filled. So glomus mastoidalis, or B2 type or B extensive B tumors, class B tumors, may not be completely come under control only through this mastoidectomy approach. So we may have to do the extensive surgery and complete obliteration of the cavity after removal of the tumor. Thank you. Okay, one photo I have to see, show just a picture. Just give me 1 minute. This is important what Narayan has been talking about. This is glomus jugular, and here it was C3. So how facial carotid can be, this is the carotid completely exposed from the carotid foramen up to the horizontal part, and it can be easily lifted to remove the tumor medial and anterior to it. So once the carotid is not involved, we can remove the bone from around the carotid and keep removing the last extent of the tumor from around the carotid. That's all.
Madhuri, thank you very much for clear and crisp videos and pictures as usual.
Thank you.
Thank you. Sampath, you want to go on with your video?
Yes, yes.
Just a quick 7 minutes, 6 minutes,
Sure,
whatever.
Sure. Is my presentation visible?
Yes.
Yes.
So I'll go with this case. So massive tympanojugular paraganglioma, intracranial extension, infiltrating onto the surface of the brain. Complete low cranial paralysis.
Close your eyes.
Low,
Lift your eyebrows.
low cranial paralysis, complete facial
Below.
paralysis.
Okay, say
Operated twice before.
loudly. Put your tongue out. Left. Okay, lift your shoulders. Both the shoulders.
So infratemporal fossa excision, 1-year-old facial paralysis, operated twice before. Mastectomy and infratemporal fossa exposure. I have isolated the facial nerve. The facial nerve is practically useless, infiltrated the tumor. Despite all the attempts, it was not salvageable. Decided to sacrifice the nerve, and then the tumor exposure commences, carotid exposed. This is the petrous portion and the dural residual of the tumor. Carotid is completely, this carotid was stented, and the carotid was dissected, facial nerve was grafted, and at the end of it, this is the stent of the carotid. You can see the carotid stenting. Is my cursor visible?
Yes.
Okay, so and post-operatively we had this dural residual. You'll see this dural residual here. That was decided to be approached with a wait and scan approach. Within 8 months, very aggressive tumor. Within 8 months, we saw that the dural residual, after 18 months, sorry, the dural residual had grown in size to practically double the size with a nice petrous extension. So this is post-op facial nerve recovery of the grafting at the end of 6 months post-op. So you see that without a lid loading procedure, without any facial aesthetic procedure, we have been able to give him a grade 3 practically. So his lower cranial nerve function had recovered. So so there was a compensated lower cranial nerve paralysis. His fees showed that there was slight pooling of saliva on the right side, but otherwise a good compensated lower cranial nerve, after the first procedure. So intracranial extension had to be removed. So I went in the second time. So this is the labyrinthine block preserved intentionally to serve as a landmark in the second stage. So this is the fat of the first stage. The whole dural element is now being visualized. So this is the dural compartment of the tumor. The internal artery meatus is being drilled out and isolated. So once the internal artery meatus is completely drilled out, you see the facial nerve, which is the rerouted facial nerve. This is all fibrous tissue and fat from the previous surgery. The tumor is underneath the dura. You see no tumor above the dura. You see absolutely no tumor in the erstwhile infratemporal fossa. So all this tumor is now intradural. So I open up the dura, intracranial cavity, dissecting the tumor away. So this is now reflected under surface of the dura with the tumor. The ICA loop is clearly seen. Now I have exposed the root of the facial nerve here. The facial nerve is being dissected in the internal artery meatus. This part here is the internal artery meatus. You see the facial nerve, the tumor being separated from the facial nerve because there was an intracranial involvement of the face. So this is the facial nerve in situ, the tumor separated from the facial nerve. Now this is intradural. This is the nerve root junction of the facial nerve, ICA loop. The prepontine cistern here, the pons here, complete resection of the tumor being achieved, and you see no tumor in the intracranial cavity. Facial nerve testing showed that the tumor has been completely resolved. Now, post-op scan revealed a small residual in the right in the center of the petrous apex. This part here had to be removed, going down into the clivus. So this is, again, you see the stent. You see the stented carotid here. You see the stented carotid lower down. These are embolized part. So this part had to be removed, went in for a middle cranial fossa approach. So middle fossa, classic middle fossa approach, brain retracted. The V3 being seen here. So this is the V3, this is the V2, sorry. And then I transected the V3, petrous carotid seen, tumor behind the petrous carotid. Complete resection of the tumor done. You see the carotid here. Carotid has been transposed anteriorly using a tape. And this is the tumor here being dissected out. So once the tumor dissection is complete, you see this is the tumor here. Dissected, and then I put fat. So this is the final cavity here, carotid being transposed anteriorly. And then I put fat. And this is his final facial nerve recovery, his final status after this, the third surgery. So we took 3 surgeries to achieve total tumor clearance. Now this is a massive C4 in a female with left-sided all cranial paralysis, fairly large tumor, C4, facial nerve intact, but low cranial nerve paralyzed, tumor being seen through the otoscopic examination, infratemporal fossa approach, facial nerve monitor applied. I use facial nerve low cranial monitor in all patients. This was also operated before, so this is a pre-operated cavity. We get a lot of post-operated residual tumors, so we're doing a blind site. And then I have done a canal wall down, complete resection of the tumor in the mastoid area and moving into the middle ear cleft. So canal wall down. Now in the neck, I've identified the vagus, the internal jugular vein, the spinal accessory nerve, the glossopharyngeal nerve there, carotid being shown here, internal carotid artery, all being taped and controlled. Once all the structures in the neck are exposed, we go ahead and so once the structures in the neck is taped, we go ahead and deal with the tumor per se. The facial nerve is rerouted. Facial nerve is intact in this case, rerouted anteriorly. So being rerouted here, embolization gives a fairly bloodless field. We have good radiologists, neuroradiologists, and for stenting, I have a very specific neuroradiologist to whom I refer these patients. So anti-rerouting of the facial nerve done, styloid process seen and excised, completely excised, styloid process excised, the IJV being ligated at the lower segment. At the upper segment, we have closed the sigmoid sinus in 2 areas, and this is the tumor per se. The tumor being completely identified in all its quarters, the anterior, posterior, superior, inferior quadrants, IJV being reflected in toto, and tumor is still being seen. Complete tumor. This is the carotid here. Anteriorly, the carotid going down like this. Carotid being pushed forward, kind of, a deviated carotid seen, and complete tumor resection achieved after resection of the. So, so if the bone looks like this, whitish, then you have achieved complete tumor resection. The cochlea has been preserved, and that's the total tumor resection after achieved at the end of the surgery. So that's the resection. You see air pockets in the deepest part of the part where the tumor was there, which means that we have reached the deepest part. Transient facial nerve paralysis on the way to recovery. This is, I'll skip this case. This was in a young boy. I'll show you a fallopian bridge technique. Now, in this case, a C2, I tried a fallopian bridge technique. I observed C1 till this turn into C2. So here you see that we have isolated the tumor, blind side closure done. A great auricular nerve identified, although I use a sural nerve in all my cases. Digastric muscle reflected, cut and reflected, after which you identify the IJV. Carotid is identified, internal carotid artery is identified. The whole mastectomy, craniotomy is done. Posteriorly, tumor excision complete. Anteriorly, tumor excision pending. So there is tumor here. So we've identified the tumor. I have put a tape around the carotid and the IJV. Going forward to resect the IJV here. You see the facial nerve is here. The facial nerve is preserved in its cavity, in its canal. Now I have, what I'm trying to do is to go anterior to the facial nerve, posterior to the facial nerve, and obviously inferior to the facial, infrafacial, retrofacial approach, and pushing the jugular bulb superiorly, the jugular vein superiorly. I have closed the sigmoid sinus here. I've gone in for a bone-anchored hearing implant. We now we do bone-anchored hearing implants or ossea implants for all our patients who undergo skull-based surgeries. We have the Asia Pacific's largest series of 9 ossea patients, 9 ossea, and we were the first to do ossea in skull alongside skull-based surgery. So you see, this whole thing is being resected out, and then so that's the part posterior to the facial nerve. This is the retrofacial part. I think a few slides are, have gone back and forth. So here you see the IJV being clipped, and this is all tumor. The IJV with the tumor, retrofacial. You see I'm passing a cotton ball both anterior and posterior to the facial nerve. I'm pushing the tumor below, drilling under the facial, retrofacial approach. And this is all tumor resection along with the IJV. IJV tumor completely resected. Carotid is here, anterior, cochlea is here. Complete tumor resection achieved with the with the fallopian bridge technique. It's very difficult to do this. It took a lot of my time and patience. So, so that having been done, I want to show you one last case.
But we'll have to cut short for want of time.
Yes.
Getting indicators.
Okay.
So.
Can I show the stenting of the carotid? There's this one picture that
just take half a minute, yeah.
Yes. So this is where the carotid has been stented. So there are 2 tumors. One is carotid body tumor. Another is a vagal paraganglioma. You see the stent. You can see the stent of the carotid going through. I have, in this case, preserved the hypoglossal nerve. I have preserved the vagal nerve, despite it being a vagal paraganglioma. Spinal accessory nerve has been preserved. Glossopharyngeal and the superior, the superior thyroid nerve has been preserved. You see, this is the so the second tumor was the vagal paraganglioma, vagus nerve, vagal tumor. So I'm dissecting the vagus. I'm doing a vagal shaving here. The carotid body tumor obviously has been taken out. So this is the vagus nerve, vagal, and all the time using the nerve monitoring system. So here you see the last bit of tumor being taken out. So this is the glossopharyngeal nerve. I'm using the copulation to good effect, the posterior pharyngeal, the lateral pharyngeal wall, and then final tumor resection after preserving the hypoglossal, vagus, spinal accessory deep within the glossopharyngeal, and the supralaryngeal nerve. Yes, so that's the last case. So these are all this thing to show post-op. You see the soft palate stimulation, glossopharyngeal stimulation, hypoglossal recurrent laryngeal nerve stimulation, trapezius stimulation, all structures preserved. And so this is stenting. So you can see the stent in an X-ray going all the way up to the petrous carotid. 2 tumors on one side. She's got one more tumor on the opposite side, which is a carotid tumor. She'll be coming back for this for the opposite side in 3 months' time. So that's her post-op. So I'm done. Thank you.
Okay. Okay. Sampath, fantastic work as usual. Excellent presentation. I know all you panelists have too much work to be shown, but I'm controlling all of you for want of time. So we are already overshot. May I request Satish to quickly show what he wants to show? Satish needs to go on. Satish?
Yeah, Narayan.
And then you can also summarize after you finish.
Okay. 2 things. So Narayan,
yes,
I'm not showing any video.
Yes.
I'll just add on to what Madhuri madam has shown in the video about the glomus tympanicum.
Okay.
And to add on to what we discussed for the imaging in the beginning. This is to show you how we get our imaging done. Can I show?
Yes, absolutely. Go on, Satish.
Are you getting the CT scan?
Yes.
So I said in the beginning, our first imaging of choice when you suspect a paraganglioma clinically is a CT angiogram. See, this is a CT angiogram. Of course, is a contrast enhanced CT scan. And what you see is some mass lesion sitting onto the promontory. This is promontory here into the middle ear. Can you see here?
Yes.
But you can't differentiate. See, it is going in the eustachian tube. It is continuing in the mastoid, something like this is all opacity. You cannot differentiate which one is tumor and which one is, secretion. Now to add on to the differentiation, the next image, what we get is the MRI done. Now see, this is T2 weighted MRI. This is fat suppressed T2 weighted MRI to suppress the fat and see the secretions of tumor better. Now what you see here on the promontory is these are bright secretions on T2 weighted. Too bright are the secretions and tumor which is less bright. And what you see here is the tumor which is going in the eustachian tube. Now what Madhuri madam said in the beginning, and this is most important in the tympanicum tumors, is they have attachment onto the promontory. Rest all extensions are prolapse of the tumor to the different area, not attachment. Like this tumor is prolapsing in the eustachian tube, is not taking any attachment in the eustachian tube. The tumor is arising from the promontory and going to the eustachian tube. The tumor goes to the atic, like she removed the tumor from in between the ossicles. She pulled the tumor out of that region, and the tumor doesn't have any attachment in the atic or anywhere, in the retrotympanum, anywhere. So tympanicum tumors have their sole attachment onto the promontory. Rest are all prolapses the tumor as it grows to the different regions. Now to add on to further information, what further information we can get out of the MRI? Number one, when we see the tympanicum tumor, we need to have information regarding their relationship with the carotid artery. See, this is the tumor. Now this is the contrast. The tumor is sitting onto the promontory and prolapsing in the eustachian tube. This is true tumor. Whatever in the mastoid, what we saw on CT scan was not the tumor. See here, it is not enhancing. This is secretions. This is one thing we need to know very clearly. Second thing, the relationship with the carotid artery. We know Professor Sana described these B3 tumors are the one which involve the carotid artery, and those are the tumors which requires a drilling around the eustachian tube, around all these cells around the carotid artery, and that requires a subtotal petrosectomy. With this kind of a contrast MRI, you can see a clear separation of the tumor from the carotid artery. And that is very, very important to know. See, this is horizontal petrous carotid. That is the vertical petrous carotid. And see, this tympanicum tumor has a clear-cut separation from the carotid. No sequence can give better information than this. Can you see very clearly?
Yes, absolutely.
This is very important to know once you deal with the tympanicum tumor. Because if you plan the surgery from post-auricular, whatever route, and you ultimately find the involvement of the carotid artery anteriorly, you have to change to a different procedure, that is subtotal petrectomy, and then it is a surprise to the surgeon as well as the patient. And this information can be very well gained from the MRI. Now the next is about the other extension. What I can do, I can reconstruct into the 3D this MRI. And what you can see now, the superior, posterior, anterior, all extensions. See this. If I take my cursor to here, this is the tumor in the superior inferior extension. Can you see this?
Yes.
Now, what this is best seen on coronal MRI. Let me take the coronal MRI, and there is very, very important information we get out of it. There's a dynamic information which you get from DICOM. See, this is the carotid artery. That's the carotid artery. That's the horizontal petrous, genu, and becoming the parapharyngeal carotid artery. And see my tumor. Tumor is there into the middle ear, extending up into the atic. This is very, very important information to know from MRI if your tumor is extending into the atic, because then you need to plan your approach to widen the atic. You may need a good episiotomy and you can plan it before. Second, we were discussing about tumor, whether arising from the jugular bulb, if it is approaching the jugular bulb, or is a tympanicum tumor. How you can get to know? See dynamic. Can you see the jugular bulb? Very clear. And this tumor is altogether separate from the jugular bulb. See this? Altogether separate from the jugular bulb. This tumor may be reaching the jugular bulb, but this is not primarily arising from the jugular bulb. And see the jugular bulb, which is full of contrast with no tumor into it and the clear-cut separation from this tympanicum tumor. So this is the inferior extension into the hypotympanum. This is the superior extension into the atic. We could see the prolapse in the eustachian tube and the separation from the carotid artery and jugular bulb. This is all information you want to know from radiology to optimize your surgical planning and results in tympanicum tumor. That is one information I wanted to give at this platform. And second is the message you want from me to optimize the results in paragangliomas. We need to, focus on certain aspects. Number one, adequate surgical planning, adequate radiology. Preoperative evaluation should be adequate to know the complete extension of the tumor, like immediately just now what we have seen on MRI. Preoperative evaluation of the tumor extent, as well as MRI, as well as angiogram, as well as cross-flow studies once it is involving the carotid artery to plan adequately. Number one. Number two is these tumors, as Sampath has already mentioned, we have discussed so many times, this is a benign tumor which requires complete removal for cure. And for complete removal, there are two important aspects to be kept in mind once you deal with the jugular paraganglioma. Number one, which is one of the most common reasons for the so-called recurrences. It is never a recurrence, it is residual tumor which is left behind and grown back. One is incomplete removal from the carotid artery. So we need to focus on complete exposure and complete removal by means of subperiosteal, whatever dissection from the carotid artery. Number two, complete exposure by means of anterior transpositions of the facial nerve. Inadequate exposure will lead to inadequate tumor removal and chances of complications are increased. So facial nerve exposure, carotid artery exposure and tumor removal, all these are important. So rerouting is very, very important. Third is bone infiltration. One of the most important sequences of the MRI we always get done. Always in these tumors. If you look at my screen, this is tympanicum, not glomus. Of course, had this been glomus, what I would see on this fat suppressed MRI is bone marrow infiltration of the tumor. In jugular tumors, jugular paragangliomas, when they extend to the jugular foramen, they tend to involve the bone of the petrous apex, bone of the clivus. That marrow is infiltrated, and if it is overlooked, this tumor is going to grow back. That missing the information of bone marrow infiltration can lead to so-called recurrence, and that is best seen on fat suppressed MRI. Why fat suppressed MRI? The bone marrow contains fat. If there is tumor and you suppress the fat, whatever you see enhancement is the tumor, and in those situations, adequate drilling of the petrous bone or whatever bone involved clivus is required to prevent so-called recurrence. And lastly, the field, the surgical field is very, very important. Like Sampath has mentioned about the embolization in his experience. If you have an expert intervention radiologist and the patient is affording, embolization is one of the best way to reduce the bleeding. The goal is to minimize the bleeding by means of catching the vessel by means of embolization to maintain the visualization. If there is too much of bleeding and you work in that field, the chances of leaving the tumor behind are high. So in order to optimize the result, you need to keep in mind all these factors to get the best results.
Thank you, Satish, for a very elaborate discussion. And can you stop your screen sharing?
Yes,
Can
yes.
Is there anything else any panelists want to this thing? I think Vijay, we are way beyond time. I say it's been a thoroughly enjoyable panel for all of us because these people are so learned and they have so much to share. I really didn't anticipate this panel going beyond 2 hours. And I think it's gone almost close to 3 years and we still have lots to show. I really hurried these people up. I'm sure each one of them can have 1 hour sessions at a different time. We can take this at a session as a lot of people have suggested. So my personal thanks to all the panelists for sharing their wonderful work and the wonderful insights to all of you all. And Vijay Krishnan, thanks a lot for giving me an opportunity from IAOHNS and Dr. Gautam Khon, Dr. Mohan Kameshwaran to actually conduct this panel. It's been a privilege from my side to question these eminent panelists and even learn from them. Thank you.
Thank you very much. So on behalf of Indian Academy of Otorhinolaryngology Laryngology Head and Neck Surgery, I would like to place my sincere thanks to this entire faculty who has joined for this live webinar discussion on this Sunday evening. And also I would like to thank the participants who are nearly about 950 across India and few from Middle East who really encouraged us to conduct more programs like this. And I'm sure this topic can be discussed for a whole day, as you said, and our moderator, Dr. Narayan Jaishankar, has clearly got the crust of message possible and important messages about skull-based paraganglioma from the faculties who are key leaders in this field. So I would also like to thank GSK, especially Mr. Keshav Shankar and his entire team who are really working behind this program to help spreading the knowledge, which is the main aim of our Indian Academy. So next program is going to be in May 2nd weekend with different interesting topic. And I would like the participant to visit www.iaohns.com for the update. And I would also like to welcome all to be the part of IAOHNS by becoming a member of IAOHNS, and you can download the membership form and send it to us. Thank you once again. Thank you, the moderator, Dr. Narayan Jaishankar, and all the faculty. Thank you once again. Bye.
Thank you so much. Thank you. Thank you, Dr. Narayan. Thank you, Raghu. Thank you, Vijay. Madhuri Madam, thank you so much. Satish sir.
Thank you. Thank you all for giving this opportunity once again. Thank you.
Madhuri is muted. Madhuri is saying something. Satish, go on. You want to say something? Satish, you wanted to say something?
I wanted to thank you.
Oh, Satish, I should thank you for coming. I know what the problem was, but I thank you for coming in late. Okay. I think the panel was enhanced with your presence. Yes, Madhuri.
Yes, definitely. Without him, it would not have been possible. Narayan, thank you very much for coordinating so well. And Sampath, thank you for being there. We really enjoyed every moment of it. Thank you very much.
Thank you so much.
Okay, bye.
Thank you, Raghu. Thank you.
Have a good evening. Thank you.